Please start in 3, 2, 1. Please start, sir. We are live.
Okay, so good evening, everyone. So it's a great pleasure to welcome for today 2 days webinar, Advancing in Cancer Care, Clinical Updates in Lung and Breast Cancer. So today we can discuss about the lung cancer, and I would like to invite Dr. Priyanshu Chaudhary sir to give his introduction. And he is consultant medical oncology, IV Hospital, Mohali. So it's over to you, sir.
So, a very good evening to everybody. So, today is day one of our 2 day live webinar in advances in cancer care. We'll be focusing on lung cancer on day one, and breast and other common cancers on day two. So, for today, we have various topics ranging from neoadjuvant and adjuvant therapies in early lung cancer to we have then pathology discussion and then stage 3 and 4 lung cancers, including those with driver mutation. So for the first talk today, I'll be inviting Dr. Praveen Jain, who is senior consultant and head of department medical oncology at Akash Healthcare Delhi, to deliver his talk on neoadjuvant and adjuvant immunotherapies in early stage lung cancer. Over to you, sir.
Thank you, Priyanshu. Let me share my screen. I hope my screen is visible.
Yes, sir. Make it full screen, please.
Yes. And I'm audible too?
Yes, sir.
Okay. So good evening, everyone. So thanks, Priyanshu, for giving me this opportunity. And the talk which has been given to me today is talking about neoadjuvant and adjuvant immunotherapy in early stage lung cancer. So it's a burning topic these days, and over a period of last 2 to 3 years, so we have plethora of trial which have established neoadjuvant and adjuvant use of immune checkpoint blockade in early stage lung cancer, and we will be discussing all the aspects of these two strategies, the nuances, the benefits of using immune checkpoint blockade in early stage lung cancer. So to set the ball rolling, lung cancer is the leading cause of cancer-related death, and it accounts for almost 1.8 million deaths annually. If looking at the lung cancer diagnosis, majority of the patient they have non-small cell lung cancer, and only for 15% of the patient they have small cell lung cancer. And out of these non-small cell lung cancer, almost 70% they present with the unresectable or advanced stage disease, and only 30% of the patient they have resectable disease at diagnosis. And it is an unmet need because the overall survival of these patients, so they are dismal. And in the figure below, it is seen that it is shown that in a stage 1b tumor, so the 5-year overall survival is 65 to 75%. So there is definitely an unmet need over here. And if we go towards stage 2, stage 3, so the overall survival, 5-year overall survival is ranging from 30 to 45%. And here we are not talking of stage 3b and 3c, which have even poorer overall survival rate at 5 years. So 30 to 70% of patients with locoregional disease who have undergone surgery, so they experience reoccurrence following complete surgical resection. And if we look at the bar graph down, so we can see that at 12 months, 40% of the patient they had recurrence in stage 3A disease, and in stage 1-2 disease only 8 to 10% of the patient they had recurrence. And we can see that the recurrence rate that stabilized after 4 to 5 years of follow-up period, then at 6 to 7 years, so there are hardly any new reoccurrences which are happening. Stage 3 population is a very diverse population. So in this figure, we can see that it starts from N0 and it goes to N3. And if we look at the T4 status, T status, so it goes from T1 to T4 as far as the tumor staging is concerned. So stage 3A, which is T4N0, T3, T4N1, T1, T2, N2. So these are considered as stage 3A disease, and these are upfront resectable diseases. So these are potentially resectable diseases. Looking at 3B disease, so it is T3, T4, N2, or a N3 status with T1, T2 tumor staging. And looking at the T3, T4, N3 status, so it is stage 3C. So starting from 3A and a subset of 3B, which is N2 positive disease. So these are potentially resectable. So now N2 also you have to see, so whether it is a single station N2 or a multi-station N2, a bulky N2 or a very small kind of burden in mediastinum. So these have to be treated separately. So there is so much of heterogeneity in stage 3, and the management of the disease with bulky station, bulky media, multiple station N2. So it goes more towards stage 3C disease. And looking at stage 3B with N3, again it is treated with the concurrent chemoradiotherapy. But we have to focus on this particular subgroup to improve the outcome of these patients. And here it is seen that all the stage 3 disease patients who are potentially resectable, who are at any point of time going for surgical management, they should be initially treated with systemic therapy just to get the knowledge about the tumor biology. And at the same time, if we can shrink the tumor, maybe the complications of surgery might reduce. But the resectability status, it is judged and it is labeled as a resectable or unresectable on the basis of initial staging per se. And after systemic therapy, you cannot call a tumor which was initially unresectable as resectable. So when we are talking of stage 3 disease, that almost all the patients should have received a systemic neoadjuvant therapy. So but the UK audit data from 2017, so it tells us that only less than 22% of the patient with stage 3A and less than 5% of those with stage 3B received surgery as part of their treatment. So this is a discordance over here, and probably I think we have to work more on a stage 3 disease, because these are the patients which, if treated in multidisciplinary setting, so these have better outcomes and they are treated in a better way with a neoadjuvant therapy followed by surgery. Looking at the evolution of neoadjuvant immune checkpoint inhibitor in early lung cancer, so the initial phase 2 study of nivolumab, so where it was used as a single agent for I think 2 to 3 cycles. So it definitely increased the major pathological response and pathological complete response. On the top of it, a dual immune checkpoint inhibitor was also tried. So it also led to more pathological complete response. However, the grade 3 or more toxicities, they were numerically more with the dual immune checkpoint inhibitor. So that was the reason that only a single immune checkpoint inhibitor combination with chemotherapy was further tried. And the rationale of adding chemotherapy to immune checkpoint inhibitor was that probably the chemotherapy will increase the antigen presentation, and it will make a more conducive environment for immune checkpoint blockade to work in these patients. So these are all the trials, so which are tabulated with the immunotherapy as a single agent or immunotherapy along with platinum based combination. And most of these trials, so they are phase 2 except Checkmate 816, which was a neoadjuvant phase 3 trial. So initial trials, so as we discussed, were done with immunotherapy alone, and we can see over here that the major pathological response were from 40 to 45% and a PCR rate of 15% with nivolumab or pembrolizumab. So which was with chemotherapy only 4 to 5% of path CR. So a single agent nivolumab or pembrolizumab or atezolizumab, they had increased the pathological complete responses. And if we look at the grade 3 adverse events in a monotherapy, so they were hardly any grade 3 adverse events. So these were next set of trial with Nivo EP combination where a doublet was used, and these were other monoclonal antibodies which were combined with the immunotherapy based approaches. And we can see over here, yes, the pathological complete response it increased. So, but if we look at the toxicity, again the toxicity increased, and in Nivo EP trial, so it was seen in 33% of the patients. So this was a landmark trial, Checkmate 816, which we will be discussing in the subsequent slide, which established the role of Nivo along with platinum-based doublet as a neoadjuvant strategy. So these are the strategies which we have in early non-small cell lung cancer at this point of time. So our first strategy is the neoadjuvant immunotherapy, where immunotherapy is only given for 3 cycles along with chemotherapy, and the trial was Checkmate 816. And after that, surgery was done, and that finishes the treatment. The second approach is as an adjuvant strategy, where initial surgery followed by adjuvant immunotherapy was tried. And there were 2 agents which have been tried. One is atezo and one is pembro, and both have been approved on basis of these trials. So the third approach is probably the approach which should focus on. So that is the perioperative approach, and there are various immune checkpoint inhibitors which have been tried in this strategy, and all these strategies. So they initially had combined immunotherapy with chemotherapy, and post surgery these patients were exposed to immunotherapy for a total of 1 year. So there are some theoretical advantages of neoadjuvant immune checkpoint blockade. So the first one is that because there is lot of tumor and we are giving chemotherapy, so the antigen load seems to be higher with neoadjuvant immune checkpoint blockade, because the tumor cells when they die, so they release the antigen and it leads to better priming of immune system to these antigen. So second one is that because the patient has not been exposed to any systemic treatment, the patient is also immune competent. So there is a fit host immune system which can lead to better efficacy of immune checkpoint blockade. So the third point is there is no significant clonal evolution, and the logic comes from that when you treat a cancer, so the population becomes heterogeneous. There are few cancer cells which are sensitive to the therapy. They die off, and later on, so there is a heterogeneous type of population of cancer cell which develops, and earlier you are treating, so there is no significant clonal evolution which is seen with the cancers. Next is accurately study the effects of immune checkpoint blockade. So these are true for all neoadjuvant strategies, because we have pre and post treatment intervention tissue, so that we can look at molecular level. So what changes the drug has produced in the cancers, and are there any resistance mechanisms, or are there anything which should be in focus for improvement of outcomes with these immune checkpoint inhibitors. The next is ability to assess efficacy of the therapy. It is almost similar that when you give the therapy in a neoadjuvant strategy, so you can assess efficacy with major pathological response or pathological complete response as the endpoint, and it somehow leads to shortening of the time frame to completion of trials, and the drugs are available at an early time point, and somehow we are improving the outcome of these patients in a very short span of time. So regarding the trial endpoints, so the major pathological response. So during the chemotherapy era, so this used to be the appropriate endpoint, which was major pathological response, because there were hardly any patients who used to develop path CR. So after availability of immunotherapy, chemotherapy combination. So the PAT-CR also has become a very valid and important endpoint. And
Praveen sir, sorry for interrupt you. Kindly conclude your talk in 2-3 minutes. Sir.
okay, okay. So these are the trial endpoints. So I'll talk of three studies. So one is Checkmate 816 study design. It was a neoadjuvant strategy. So where stage 1B to 3A non-small cell lung cancer, they were included in this trial. And Nivo plus chemo was compared against chemo. And after that, within 6 weeks, surgery was done. And the primary endpoint was PCR and PFS. We can see over here that almost 83% of the patient post Nivo chemo, they underwent surgery. And if we look at the chemo arm, 75% of the patient they underwent surgery. So there was no decrement in the surgical management with addition of Nivo. Looking at the PCR in all the stages, there was a PCR advantage which was seen in favor of Nivo plus chemo. So this was the event-free survival. The median EFS has not been reached in Nivo chemo arm. And if you look at the chemo, so it is 21.1 month. Looking at the 3-year rate, 57% versus 43% in favor of Nivo chemo. So the next trial is AGN trial, which is the perioperative strategy. Here, stage 2A to 3B patients, they were included in this trial. And Durva along with chemotherapy was given as a neoadjuvant strategy for 4 cycles, followed by surgery, followed by Durva placebo for total of 12 cycles. Looking at the PCR, again, the same kind of thing which we are able to see here. So the PCR improved and the MPR also improved with the addition of Durva to the chemotherapy. So these are the PCR according to the by subgroup in the Durva versus placebo arm. And we can see across the subgroup, so there was benefit in favor of durvalumab. And if we look particularly at the PDL1 expression, again, higher the PDL1, more was the PCR. But the benefit of Durva addition was seen in those with the PCR, those with the PDL1 negative population also. So this was the EFS median is not reached with Durva, and the for placebo it is 25.9 month. And again, the EFS by subgroup, almost all the subgroup they had equal amount of advantage. So this is the third and final study, Keynote 671. So again, it is a perioperative therapy where Pembro Gemcis or Pembro Pemcis. So it was given for 4 cycles, followed by Pembro versus placebo. And these were the event-free survival which was seen with this. And it was better with Pembro, and we can see at 2 years 62.4% EFS as compared to 40.6% with the placebo arm. Looking at the overall survival again, the data is still not mature. We have to look for the maturity of the data, but there was a trend towards improved overall survival also. Looking at MPR and PCR, both were significantly improved with addition of Pembro to chemo. So to conclude, neoadjuvant immune checkpoint inhibitor, it has certain sorry, one second. So neoadjuvant, it has certain advantage. It provides early opportunity to eradicate micrometastatic disease. It has increased treatment initiation rate and compliance rate. The pathological response provides early indicator of response to therapy and can guide future treatment decisions. And it can potentially eliminate live tumor cell released into circulation during the surgery. Whereas the adjuvant strategy, so it allows the fastest time to surgery. So the patients, 7% patient who were not operated in 816, so they will be eligible for surgery. So there was no risk of pre-surgery complication from systemic treatment. So it enables longer treatment duration for systemic control, and it is more flexible as far as the timing post-surgery is concerned. So these are the recommendations for neoadjuvant therapy, that for medically operable patients with oncologically resectable stage 3 non-small cell lung cancer with N2 disease for whom surgery is planned, preoperative systemic therapy without radiotherapy is recommended. But those patients with superior sulcus tumor where radiotherapy should be given, a preoperative concurrent chemoradiotherapy is preferred. So as far as the choice of therapy, platinum-based doublet along with immunotherapy, uh, as per 816, nivolumab can be given, and as per the perioperative approach, all these immunotherapies, be it Durva, be it Pembro, Nivo, Toripalimab, or Tizo, so they are available options. For eligible patient with resectable and medically operable stage 2 and 3 non-small cell lung cancer, neoadjuvant platinum-based chemotherapy with immunotherapy is preferred over adjuvant therapy. Thank you. So thank you for patient listening, and if there are any questions, I'll be happy to answer them.
Thank you, sir, for this lucid presentation. I think so we are running behind time, so we would skip the questions. And thank you again, sir. So for next session, which is sponsored by Lalpath, I would like to invite Dr. Vamsi Krishna, who is Head Genomics and Clinical Cytogenomics, for his talk on NGS analysis of tumor tissue versus liquid biopsy. Over to you, sir.
A very good evening to everyone. I'm just going to share my screen. Can you see my screen?
Yes,
Yes,
sir.
sir.
Okay, wonderful. So my topic today is NGS, or next generation sequencing analysis of tumor tissue versus liquid biopsy. What happens in the laboratory is what I'm going to elaborate here. Basically, a molecular pathology, has different platforms, different tests that we kind of look at towards tumor profiling. There are two, different subdivisions in the form of cytogenetics and genomics. Cytogenetics most commonly is used by the hematolymphoid malignancies, wherein we're kind of trying to look at karyotyping and FISH to understand which molecular signatures that we're looking at, especially BCR-ABL or pMRARA. And then for genomics, when we are looking at sequencing, it is Sanger sequencing, which is the gold standard. The MLPA, which looks at copy number variations. Next generation sequencing is what we are in the era of. So I'll talk about next generation sequencing. Pyrosequencing is the gold standard for looking at gliomas, especially for the O6 MGMT methylation analysis. Real-time PCR, as we all understand, that's the quantification of or the MRD monitoring of various diseases that we see. And the most sensitive technique, more sensitive than the real-time PCR, is the droplet digital PCR, wherein we can look at even one copy of BCR-ABL in 1 million, wild-type copies. So we are in the era of next-generation sequencing. While we talk about the next-generation sequencing, what was the previous era of sequencing? This was the first-generation sequencing devised by Frederick Sanger in the year 1977. This is the sequencing which has led us to kind of sequence a reference genome of humans in the year 2004. This was also called as a chain termination method, wherein a double-stranded DNA is denatured. Copies of that denatured or the single strand are made, and then we attach a primer. A single primer which attaches to a gene or a gene target of interest. There are 4 nucleotides that we are made of, the A, T, G, and C, and these A, T, G, and C, A, T, G, Cs are added to this elongating chain, and based on the complementary nucleotides, A to T or G to C, the strand gets elongated. And these strands are electrophoresed, and then we understand the sequence. When there is a dideoxynucleotide which is incorporated, the chain gets terminated. Whichever chain gets terminated, it travels to a lesser extent in the electrophoresis, and that's the first, or they are the first initial sequences. So when you look at this sequence, the lower sequence is the human reference sequence, and the top sequence is the mutation, or rather the sequence of the tumor tissue or the liquid biopsy that we are looking at in the Sanger sequencing. And we can see that there is a G to A change in the tissue that we have tested. This is the first generation sequencing, or the Sanger sequencing. And fast forward, we go into the next generation sequencing. In the next generation sequencing, it is not just one gene or one target region of interest. It's multiple regions, multiple gene targets of interest that we are doing all at the same time. So that's why it is also called as the massively parallel sequencing. NGS is also called as the MPS. So this massively parallel sequencing sort of sequences multiple gene target regions of interest, and these genes target of interest are laid out against the reference genome, and we see if there is any mutation present in those specific genes or those specific nucleotides in the exons. This is the NGS workflow, be it a tumor tissue or be it liquid biopsy. Initially, the sample is collected, from which the nucleic acid is extracted either in the form of DNA or RNA. RNA is mostly used for detecting the fusions. For example, in the lung cancer, the AL cross RET MET, these fusions with the specific gene partners are detected in the RNA. The RNA is much more sensitive than detecting that gene fusion on the DNA. So the RNA is useful for gene fusions, whereas the DNA is useful for all the other applications in the form of single nucleotide variants, nonsense, missense variations, the indels or insertions or deletions, then the tumor mutation burden, the microsatellite status, as well as the homologous recombination or the HRD status as well. The DNA and the RNA, once they are isolated, what we do is we prepare a library. Why are we calling it as a library? Because library has many books, and many books is akin to many regions or many genes of interest, and these genes of interest are prepared and pooled into a library, and this library is sequenced. When we sequence them, we get all the ATGCs, and these sequences are read out in the form of a raw data. This raw data, we are looking at quality control. Either it's a good data or it's a bad data. And once we understand that it's a good data, we align those sequences that we got against the reference genome. And this reference data and the sequence and the sequences from the tumor tissue is what are aligned. And when we see that there is a change in the nucleotide, that's what we call it as a variant, or that's what we call it as a substitution. That base substitution is called out as a variant, either in the form of a deletion or in the form of substitution. So this variant that we called out as being either deletion or causing substitution is further deciphered at the level of protein, and we call whether the protein has changed or whether the protein has got terminated. So that's the variant annotation or the effect prediction. So this is the broad workflow. What happens, to the sample? The sample gets prepared, sequenced, variant is called, and then a clinical decision is made based on the variant that we are finding out. So this variant filtering is what we call as a variant calling file. This variant calling file is something which we get from the sequencer. Once we get a variant calling file from the sequencer, we do the variant filtering. Most of these variants, most of these changes are what are called as the polymorphisms. Why? Because they are present in more than 1% of the population. When we see that the variant is rare and it is present in very less number of the members in the population, when we see that these are not synonymous variants, and when we also rule out that these are not benign variants which are already reported in ClinVar, that's when we give significance to that variant. And when we give that significance, the significance is still not certain. When does the significance become certain? When we attach that particular variant to whether it has been published, whether it has been established, whether it has been targeted as part of the phenotype. So this phenotype-genotype correlation is what is important for us to give the interpretation or prioritization to that variant in a specific cancer type. All of these different databases that we look at when we are looking at calling out a variant, say in any of these population databases, is that variant present or is that mutation present? In any of the prediction tools, these are the in silico parameters. These are like the in vivo, in vitro. So in vitro, has this variant been caused to, does it lead to a protein, to a deleterious protein? Does it cause pathogenicity is what the prediction tool tells us. The prediction tool has to tell us whether it is deleterious or pathogenic. The population needs to tell us that yes, it is present in very less members of the population, so it is relevant. The phenotype is what it needs to match, and based on the variant being published in the ClinVar or in PubMed, we kind of give that variant out, as part of the mutation testing. If we are looking at the coding DNA 1799. At the 1799 position, if there is a T to A change, that is causing the protein of the BRAF in exon 15 from valine to becoming glutamic acid at 600 codon position. So that's a V600E. That's what is the variant annotation. what all different changes that we are checking at the allele level? So on the allele level, I can see that these are the different reads, if I'll call them as reads, and these are the reads which are generated, or the sequences which are generated when the tumor tissue was subjected to amplification in the form of library, and then it was sequenced. So when I see that there's a copy number gain, when there is I can see that there's a copy number loss. There can be insertions and deletions wherein there are missing nucleotides in a specific manner. There can be point mutations. In this point mutation, there are substitutions of what nucleotide was present, but the other nucleotide has replaced it. Or there can also be translocation breakpoints wherein we can see that the BRAF has fused itself with KIAA1549. So this is a BRAF translocation. There can be a BRAF point mutation, and insertion, deletion, loss, or gain. So this is what is called as the integrated genomic viewer, and this is the visualization of whatever sequences that have gone into the sequencing machine. Apart from allele level changes, there can also be allele configurations wherein there can be one wild type and one mutant allele. So there can be heterozygous, loss of heterozygosity. There can be focal amplifications, like for example, HER2 amplifications. There can be genomic losses, like for example, a whole arm can be lost, or maybe at the gene level there can be a loss. A copy neutral loss of heterozygosity is called when there is a wild type allele which is lost, and there is both the alleles which are present are not there is no wild type allele, but there is only a mutant allele which is present. There can be a whole genome duplication, and there can be all other forms of imbalances at the allele level configuration on the whole chromosomal level. There are specific mutational signatures which are being described for different cancers, maybe at the level of diagnosis or at the level of metastasis as well. There are various structural variants that we can see at the level of chromosomes as well. So NGS also, as I mentioned earlier, it's a massively parallel sequencing. There are various applications on the germline, on the prenatal or the reproductive diagnostics, on the infectious parameters, especially looking at the microbiomes these days, as well as especially in the field of oncology. When we talk about tissue biopsy versus liquid biopsy, if the tissue biopsy is subjected to next generation sequencing, one, we need to understand that it's an invasive procedure for the patient. It takes a little longer time. Why? Because most of these biopsies initially get subjected to a formalin fixation and paraffin embedding. Why? Because we are traditionally bound to understand what is the morphology of the specific cancer. Is it a lung cancer? Is it a pancreatic cancer? Is it an adenocarcinoma? Is it a lymphoma? All that histomorphology, if we have to look at, we will have to do the FFP section. So it takes a longer time for that for us to understand that yes, it's a carcinoma or it's a non-small cell lung carcinoma, and so we have to go into the subsequent step, which is the next generation sequencing. There is a high cost of sample isolation as compared to liquid biopsy, but then I think that's taken care of. These are clinically validated assays which are widely available as compared to liquid biopsy. It provides a serological evaluation and narrows down to a diagnosis or a differential diagnosis, as I mentioned earlier. It is not capable of assessing the tumor evolution. Basically, we do not understand the entire heterogeneity of the tumor, because when we take a biopsy, we only take a biopsy from one part of that specific tumor. The entire tumor might have a different molecular signature. Other parts may have different molecular signature as compared to the one where we have biopsy. We cannot do a real-time monitoring of the drug response, and there are tumor heterogeneity issues which are solved by having a liquid biopsy, which is a minimally invasive. It takes a shorter time because there is no fixation required. It's a very highly sensitive, sort of technique as based on how much of depth that you're looking at. There are many labs where now they are clinically validated liquid biopsies which are present. Obviously, it does not give you a histological evaluation, but it gives you a very good tumor heterogeneity. It gives us the advantage of real-time monitoring, and it also gives us any evolution of any mutations or any resistance mutations as well. Liquid biopsy, as I mentioned in this particular slide, I was talking of next generation sequencing on the circulating tumor DNA only. I did not talk about the circulating tumor cells or the extracellular vesicles, which are other forms of the liquid biopsy checking for mutations and other resistance mutations. Liquid biopsy as a standard of care, the College of American Pathologists, the ISLC, the AMP, as well as the other testing societies basically regulate the industries, pathology and molecular testing guidelines. But whereas the treatment guidelines usually come in with ASCO and the NCCN. This is the NCCN guidelines for colon cancer. Obviously, when we are not able to find mutations on the solid tumor, on the tissue biopsy, and when it is difficult, then obviously we can always use a liquid biopsy. Obviously, we understand that there in non-small cell lung carcinoma as well, there's lots of role of circulating tumor DNA as as liquid biopsy, and there are very well validated labs in which the assays is available these days. ctDNA obviously has multiple potential applications, as I mentioned earlier. One, we can use it for screening. Two, we can characterize the early disease. We can look at the MRD monitoring after a therapy in the form of targeted therapy or systemic therapy. We can predict relapses. We are looking at genotyping the advanced cancer. What is the mutational status or what is the resistance status of a mutation, of a specific mutation which has been targeted? There can be early assessment of treatment efficacy. We can monitor the response. And obviously, we are looking at the various resistance mechanisms, either in the form of single nucleotide variants or in the form of tumor mutation burden or the HRD status. This figure that you're looking at is the mutation allele fraction. So this mutation allele, the variant allele frequency is what we understand. So the variant allele frequency at diagnosis of the ctDNA is high or the tumor DNA is high. And once we are looking at the follow-up, it is very much easier for us to track the ctDNA as compared to tissue biopsy, wherein it would require an invasive biopsy to be done. So be it at early stages or at advanced stages, the biomarkers for on the liquid biopsy are easy to follow up. However, there is an inability to detect a variant, which can be due to absence of that variant in the patient's cancer, or there must be a very low fraction in for a higher depth that we're not looking at. So there could be a false negativity also in a cell-free DNA or a circulating tumor DNA. Basically, in patients who are unfit for tissue biopsy or additional tissue biopsy, where there is insufficient material, a liquid biopsy can be done. Even on progression, liquid biopsy can always be looked at. A circulating tumor DNA can be subjected to NGS because it looks at reduced turnaround time, and there is always an increased yield of targetable alteration detection because of tumor heterogeneity. So tumor biopsy versus liquid biopsy, basically there's advantages and disadvantages of tumor biopsy, which are the disadvantages of tumor biopsy are actually very well met by the liquid biopsy these days. We are in the era of precision medicine when I'm talking about next generation sequencing used for tumor tissue, used for circulating tumor DNA, but also can be used for peripheral blood, which is your germline DNA as well. So these markers are point us towards not only the diagnosis, but also towards therapeutic medicine. And they also give us an indication towards the heritable risk. So all of this, the heritable risk, the definitive diagnostic molecular markers, as well as the therapeutic biomarkers that we're looking at on NGS, together we can have a holistic view of the molecular signature which is present, not only at diagnosis as well as at the metastatic setting, but also not only in the patient, but also in the patient's family and the extended members as well, if they're carrying a heritable risk of these specific gene mutations which are pathogenic. Important parameters that I want to look at, that I would want us to look at in tissue biopsy versus liquid biopsy is the depth. The depth at tissue biopsy may be at 500x. I'm confident to say that yes, it's a true mutation. But on liquid biopsy, I would have to go in for a higher depth to more than 10,000x to say that yes, this mutation is present or this mutation is truly negative. An EGFR or an ALK or ROS is truly negative when I'm looking at more than 10,000x. The evolution of ctDNA started off in 1948, and now we are able to look at specific targets as well as resistance mutations for ctDNA, not only in the field of oncology, but we are also looking at in the field of microbiome, in the field of prenatal testing as well. So ctDNA has been really helpful. It has been more than 70 years that we know that ctDNA or circulating free DNA, CFDNA is present. we are reaping the benefits, now in the era of next generation sequencing. Having said that, that was my last slide. Thank you for your patient listening, and I'm open to questions.
Thank you, sir, for such a nice talk. So where do you see, I mean, both of these tests existing together, I mean, being complementary to each other, increasing the detection rate with both, tissue as well as the liquid biopsy?
I think it's a wonderful question. If you are able to, one of the most important things which has become these days is the cost effectiveness. So if the cost effectiveness has no play in the technological advancements that we have right now, it's always the tumor and the liquid biopsy which have to be done together, and that is where we have that's where the biomarker discovery actually happens. You decipher the molecular signature of the tumor, and then you look at the tumor heterogeneity, which comes out from the ctDNA, and that's when we match the mutations and we see which patients have a more rather epitope burden of a specific gene or a specific gene variant that we have. That's more of the discovery model. But having discovered them, do we have the pharmacological or the therapeutic targets to actually use against those patients? So that becomes a challenging aspect, wherein most of these do come into translate into clinical medicine, but they're still at the level of research, at the gate of coming into clinical diagnostics for us.
Absolutely, sir. Thank you, sir. Thank you so much for this talk and sparing your valuable time, sir. So now I would like to move on to the next session, which is sponsored by AstraZeneca. And for that, I would like to invite Dr. Rajiv Saini, who is Senior Consultant Medical Oncologist at Shri Mata Vaishno Devi Narayana Super Speciality Hospital, Katpa, and he'll be speaking on managing stage 3 NSCLC in real life. Good evening, sir. Welcome, and over to you.
Thank you, Priyanshu, and thanks AstraZeneca and Priyanshu for giving me the opportunity to discuss, in fact, to talk about the stage 3 management, specifically in what we are doing at our center or at tier 2 cities, basically. So let me share my screen first. So my screen is visible?
Yes, sir.
Okay. So I will discuss about managing stage 3 non-small cell lung cancer, what we are doing in real life rather than what the clinical trials were telling us. So since we are discussing how we are treating, so we'll start with a real life case. So this is a 52-year-old male who presented with a chief complaint of weight loss and dry cough with no comorbidity. And because of cough, he was evaluated with chest X-ray, which shows radio opacity in left upper lobe and middle lobe of left lung, along with perilesional haziness and mild bilateral apical thickening seen. So on the basis of finding from chest X-ray, CCT chest was done, which shows large heterogeneously enhancing lesion with necrotic component involving the apico-posterior segment of left upper lobe, along with few sub-centimeter and large mediastinal lymph nodes, which are seen likely representative metastatic involvement. So in this case, the patient came to us with this report. Then we have done PET-CT. In PET-CT, it shows metabolically active soft tissue density mass lesion of around 7 into 7 to 8 centimeter in left upper lobe, abutting the costal and mediastinal pleura in the apical segment, that is T4 lesion. And along with this, contralateral mediastinal lymph node was also present, which is N3. So in total, the patient presented in stage 3 with stage 3C to us. So CT guided biopsy was done from the left lung lesion, which shows poorly differentiated adenocarcinoma, confirmed with ISC, which is TTF positive, and the diagnosis, that is adenocarcinoma left lung CT4N3M0 lesion, was made. So coming to stage 3, as we know, stage 3 is basically very heterogeneous group of population, varies from T1, T2 lesions to T4 lesion. It also encompasses N0 lesion from N3 lesions. So the patient was, the group of population is very heterogeneous. At one spectrum of the population is upfront resectable population, and at other end, those patients who are upfront unresectable. So on the basis of the patient were divided into stage 3A, 3B, 3C. In stage 3A patient, most of the patients were either upfront resectable or they become resectable after giving neoadjuvant therapy. So if we look at the 5-year survival of this subgroup of the population, you can clearly see that in 3B, 3C population, the 5-year survival is around 15 to 25%, while it is around 40% in patients who are stage 3A. So whenever patient presented to us with stage 3, so normally we do CT, PET scan, and brain MRI. When patient has N2, N3 nodes, most of the time we are not doing invasive staging. But when patient has N2 disease or N1 disease, we go with the invasive staging to rule out the involvement, to rule out those populations which are unresectable. So there are two approaches in invasive staging, that is non-surgical and surgical. In non-surgical, we are doing EUS and EBUS. In surgical, we are doing mediastinoscopy and VATS. So why are we doing invasive staging? Because we know that radiologically, the sensitivities, the PET staging mediastinal lymph nodes, the sensitivity is around 80% and specificity is around 88%. So a good number of, we can miss a good number of patients from curative setting, as well as we can avoid unwanted surgery in such patients. So regarding the invasive staging, we can clearly see that EBUS, EUS has the highest sensitivity with 100% specificity. So most of the center, usually the mediastinal staging was done with the help of EBUS, EUS. So regarding the overview of current treatment paradigm, stage 1, stage 2, the things are very clear. In stage 3, depending upon whether patient is resectable or not resectable, either will give concurrent chemoradiation or we are doing neoadjuvant therapy followed by surgery or CTRT. In stage 4 disease, we all know what we have to do. So coming to unresectable stage 3 non-small cell lung cancer, so we have to achieve good local regional control, as we know that majority of the patient have some sort of micrometastatic extra pulmonary spread also. So we need to have a good systemic control also. And in this patient, brain most of the time act as a sanctuary site for metastasis. So this patient who is stage 3C patient, in this patient, as we have N3 node, we know that in this patient, the surgery has no role. And in this patient, either we straight away start with definitive CTRT, or in many of clinicians used to give neoadjuvant chemotherapy, then followed by CTRT in this group of patients. So we have to discuss with the patients depending upon the various patient-related factor, we either start with definitive CTRT or with neoadjuvant chemotherapy followed by CTRT. So in this case, we have counseled the patient for CTRT, but however, he was not able to come for radiation initially. So the patient was planned for chemotherapy alone, and we have given paclitaxel day 1, day 15, followed by plus carboplatin day 1 every 3 weekly. So 3 cycles of induction chemotherapy was given, And in between, after second cycle, because of hypersensitivity to paclitaxel, the chemotherapy is changed to nab-paclitaxel. And post 3 cycle of PET-CT, the partial response to therapy was seen. So what is role of induction chemotherapy in unresectable patient plan for definitive CTRT? So we have various studies which have compared the various regimes, and in fact, in PACIFIC trial also, 26% of patient has received induction chemotherapy followed by definitive CTRT. So if we in this case, after induction chemotherapy, the patient was planned for CTRT with paclitaxel and carboplatin, and he received total dose of 66 gray in 33 fraction by IGRT, and he tolerated treatment well. So coming to CTRT versus sequential CTRT, if we see the data, the data is very clear that concurrent CTRTs is doing better as compared to sequential chemoradiations. And in real world data of more than 3,000 patients, in unresectable patients, it was clear that CTRT group had favorable outcome than sequential chemo-RT, or RT alone or chemo alone group. But in many of these sequential RT group, majority of the patient who received chemotherapy initially followed by RT alone. So the clear cut, we are not very sure whether it is CTRT which benefited or it is induction chemotherapy which benefited patient. So regarding the outcome for consolidation trial also, even if the chemotherapy was given after treatment with the consolidation chemotherapy or consolidation radiotherapy or consolidation target therapy, none of this therapy has found to be found to demonstrate any benefit in patient. So in our patient, after 4 weeks, patient developed radiation pneumonitis, so he was started on steroids, and in a period of 4 weeks more, the radiation pneumonitis resolved, and patient was slowly tapered on steroids. Now, discussion after the completion of CTRT is regarding the use of immunotherapy. As the PACIFIC trial has clearly shown that with the use of consolidation immunotherapy, many of the patients benefited with this regimes. So what is this PACIFIC trial? In the PACIFIC trial, it is a phase 3 randomized double-blind placebo-controlled multi-center international study where stage 3 locally advanced unresectable non-small cell cancer who have not progressed following definitive CTRT were randomized after 1 to 40 days of completion of CTRT in 2 arm, in 2:1 randomization in durvalumab arm, which was given at the dose of 10 mg per kg every 2 weekly for a period of 1 year, versus placebo again for 1 year. And the co-primary endpoint in this study was PFS and overall survival, while key secondary endpoints were overall response rate, duration of response, safety and tolerability, and patient-related outcomes. So in this patient, majority, that 99.7% of patients had received concurrent chemotherapy plus radiation prior to study start. And in this patient also, 26% of patient has received induction chemotherapy before CTRT. So coming to the result of this trial, updated 5-year overall survival, the patient who has received durvalumab, the median OS was 47.5 months versus only 29 months in the placebo arm. And you can clearly see that 5-year survival rate is more than 40% in durvalumab arm, while it is only 33% in placebo arm. So it was the first and only approved immunotherapy drug which has demonstrated more than 40% OS at 5 years. And regarding progression-free survival also, the PFS in durvalumab arm is around 17 months, while in placebo arm it is only 5.6 months. And 1/3 of the patient were disease-free at 5 years in arm where the patient received durvalumab arm, versus only 19% of patients were disease-free, progression-free at 5 years. So again, durvalumab was the first and only approved immunotherapy drug which has shown sustained and durable PFS of 33% at 5 years. And if we see subgroup analysis also, all the subgroup, irrespective of the histology, irrespective of the PD-L1 status, were benefited with the durvalumab. durvalumab. However, the EGFR positive patient had crossed the line of unity because, and we can see that the number of patients, EGFR patients are very low. So we cannot clearly comment over it that whether the use of durvalumab has benefited or not in this group of this subset of patients. And updated OS and PFS was also in the favor of durvalumab arm, whether the patient had received prior definitive CT or not. So regarding, because after the CT-RT, many of the patients have a lot of toxicity with the treatment, and many of the patients were not fit to start immunotherapy after CT-RT. So what is the best time to start durvalumab of CT-RT? The answer is whenever the patient is fit to receive durvalumab can be started on CT-RT. So in our case, we have started durvalumab after 82 days of CT-RT because the patient has developed radiation pneumonitis, and it takes around 8 weeks for the patient to improve from radiation pneumonitis. So 3 months later, the PET-CT was done, which has shown persistent benefit with the continuation of immunotherapy. So regarding real life data on durvalumab to when to start durvalumab, so we have a study from the real live data from the France. Those they have analyzed 591 patients, and in this their plan was to start durvalumab within 42 days after the end of radiation. However, in their study, 40% of the patient has started durvalumab after 42 days of completion of CT-RT, and their results are similar to what we have seen in the Pacific trial, and that too the response was similar to what observed in Pacific study, despite almost 40% of patients starting durvalumab 42 days after CT-RT. And we have done serial PET scan in these cases, and the patient continue to have partial response to therapy, and patient has completed 1 year of durvalumab based immunotherapy after CT-RT. So to conclude that with traditional treatment with CT-RT, 5-year overall survival is to the tune of 15 to 25%. However, with the use of consolidation durvalumab, the 5-year OS has increased from 15 to 25% to more than 40%. So many of the patients are going toward cure. So even the various guidelines also in Indian expert consensus statement also, they have said that those stage 3B patients who are N2 that is deemed resectable, the addition of radiotherapy to chemotherapy before surgery does not improve survival, and may not be offered in such cases. Concurrent CT-RT is recommended due to its increased efficacy compared to sequential chemoradiotherapy or radiotherapy alone in unresectable stage 3B patients. Consolidation or maintenance of durvalumab is recommended for unresectable stage 3 patient who have not progressed on platinum-based definitive CT-RT. Similar guidelines were given by NCCN and ESMO also. So the key takeaway from this discussion is CT-RT gives better outcome than RT alone or CT alone. Consolidation CT doesn't improve outcomes, and durvalumab was the first and only approved immunotherapy who has demonstrated a 4-year OS and PFS benefit, and it should be considered as a treatment option in all unresectable stage 3 patients who has not progressed on CT-RT. And the benefit of durvalumab is irrespective of PD-L1 status. So durvalumab is the new standard of care in stage 3 unresectable non-small cell lung cancer post CT-RT. Thank you.
Thank you, sir, for such a wonderful talk. And I think there are no other questions, so we can move forward. So for the next session, which is sponsored by Roche, I would like to invite Dr. Ajit Ratan, who is consultant medical oncologist at Ojis Hospital, Panchkula, and he'll be talking about the role of Tecentriq in first-line NSCLC.
Hi, everybody. Are my slides visible?
Yeah, they will.
Okay. Thank you, Dr. Priyanshu. Thank you for having me here. We are having some wonderful presentations. it's a very good learning experience. So my job today is to address this IMpower 150 trial. It is when atezolizumab was added to the conventional chemotherapy along with bevacizumab in first-line non-squamous metastatic non-small cell lung cancer. So just for disclaimers, these slides were presented by Roche, and Roche abides by its principles of safe practices. So IMpower 150 was a phase 3. Sorry. So it was a phase 3 study of first-line atezolizumab with chemotherapy and bevacizumab in non-squamous lung carcinoma metastatic first line. So the key question it wanted to ask was, does the addition of atezolizumab in the standard of care regime of Bev plus paclitaxel and carboplatin have any added clinical benefit? And is there any improved clinical benefit if bevacizumab is replaced by atezolizumab? So in those very similar lines, around 1,200 patients were stratified, which were diagnosed as stage 4 non-small cell non-squamous lung cancer, which were chemotherapy naive and were stratified according to sex, PD-L1 status, and liver metastasis. The three arms of randomization were: arm A was combination of atezo plus paclitaxel carboplatin followed by atezolizumab maintenance. Arm B was having atezolizumab to the carboplatin, paclitaxel, and bevacizumab arm. And arm C was where paclitaxel, carboplatin, and bevacizumab was given. So in all the three arms, there was a maintenance, and the maintenance was continued till progression of disease or there was any loss of benefit of the therapy. So in the arm A, atezolizumab alone was used as maintenance. In the arm B, both atezo and bev were used till progression. And in arm C, only bevacizumab was used till progression. There were two primary endpoints. One was the PFS of the intention to treat wild type, and there was OS analysis as well in the intention to treat wild type patients. So before we go into the results, let's see how, on principle, in theory, do we feel that bevacizumab and chemotherapy will add to, or rather atezolizumab will add to the use of bevacizumab and chemotherapy in our setting. So the first thing is how bevacizumab helps in priming the tumor for a good immune response. Bevacizumab is an inhibitor of VEGF. It causes a VEGF-mediated suppression of dendritic cell maturation, enabling an efficient priming and activation of T cell responses. Bevacizumab also normalizes the tumor vasculature. Now more T cells can infiltrate because of the good vasculature into the tumor. Bevacizumab also decreases the activity of T regulatory cells and other cells and enables reprogramming of tumor microenvironment. Chemotherapy, we all know, causes cell death, which can trigger an immunogenic response and by the release of tumor antigens. And bevacizumab has the ability to restore anti-cancer immunity through a T cell mediated cell killing, which we now expect in theory to be further enhanced by VEGF mediated immunomodulatory effects and chemotherapy. Coming to the baseline characteristics of the trial, in all the three arms, there were equal proportion of patients who were male and female. The tobacco history was consisting of current smoker to previous smoker versus no smokers, all equally distributed in the three arms. Liver metastases were also distributed equally among the three arms, as you can see. So was EGFR mutation status and ALK and KRAS mutation status. PD-L1 expression, whether high or low, or whether no PD-L1 expression was there, were also distributed among the three arms. Coming to the result, as you can see, a stark OS benefit with the use of atezolizumab, that is arm B versus arm C, where only Bev and chemotherapy backbone was used. A median OS of 14.7 months with the conventional arm versus 19.5 months with the addition of atezolizumab to the conventional backbone. This OS effect seems to be carrying forward with more follow-up, and at a landmark of 24 months, the OS stood at 43% in the testing arm versus 34% in the conventional, giving us a hazard ratio of about 0.80. So it says that a median OS improvement of about 4.5 months, which also seems to be clinically meaningful. Coming to the overall response rates and the duration of response, a high proportion of patients responded to both the addition of atezolizumab and bevacizumab to the chemo backbone. About 56% of such patients have responded, as you can see in the graph arm B, versus arm A and arm C, which have about 41% of the response rates. And the median duration of response was also high, which was about 11.5 in the arm B versus 8.3 and 6 in arm A and arm C respectively. If you stratify these patients according to PD-L1 score, the benefit of addition of atezolizumab was irrespective, whether it was PD-L1 high, PD-L1 low, or PD-L1 negative. The effect, the better response rates and better duration of response was consistently seen across all the PD-L1 groups in the atezo, bev, and chemotherapy arms. Coming to the overall response rates of addition of atezolizumab versus bev plus chemo in the PD-L1 high group. In the PD-L1 high group, the hazard ratio of 0.7 was seen with a median OS of 15 months in the conventional arm versus around 30 months in the testing arm with the addition of atezolizumab. The benefit was also seen in PD-L1 positive patients, in which the median OS was about 16 months in the testing in the conventional arm versus 22.5 months with the addition of atezolizumab. In PD-L1 negative patients, the benefit did seem to be there. However, as you can see that they've eventually sort of crossed, and if you look far enough, the benefit seems to have sort of faded away. This is an interesting subgroup analysis not seen with other immunotherapy trials. Is the benefit of atezolizumab in the EGFR and other driver mutation groups. So in our trial, we had a total population of about 1,200, in which the intention to treat wild type were about 1,042, which left 160 patients be EGFR mutant or ALK rearranged. Out of that, some of the patients, about 78, also had received a prior TKI therapy in the experiment. So if you compare the arm B versus arm C, that is the addition of atezolizumab to the chemo backbone versus just chemo, in this specific patients with driver mutation positive, you can see that there's a clear PFS benefit of about 3.5 months, which has a ratio of 0.59, with a median PFS of 6.5 months in the control arm versus 9.7 months in the testing arm. It did also translate into an overall survival benefit, where arm B, when compared to C, did show a hazard ratio of 0.6 and a median difference of about 9 months in both the arm, benefiting the atezolizumab, bevacizumab, and backbone chemotherapy arm. And in arm A versus arm C, it seemed that the addition or removal of bevacizumab did not have much benefit in such patients. OS benefit in patients with sensitive EGFR mutations with prior TKI therapy. Remember, 78 patients also had received prior TKI therapy. There was a definite OS advantage, which was seen initially as median OS of 18.1 months in the conventional arm versus 27 months in the testing arm. However, it seemed that in the later part of the trial, when the follow-up was extended, the overall survival sort of diminished. Probably the patients in this arm for testing were not powered enough to find a difference. However, there is no doubt regarding the overall response rates, which seem to be better in this special subgroup of cancer patients with EGFR mutation positive. Overall response rates of about 71% versus just 42% when immunotherapy atezo is not used. And a very impressive complete response rates of about 6% were also seen in the immunotherapy arm. So what happened to patients who had liver metastasis, which was a pre-specified plan to address this issue? It seemed that patients who had a liver metastasis had a clinically meaningful survival advantage with the use of atezolizumab. A median OS advantage of about, PFS advantage of about 3 months with the addition of atezolizumab. And similarly, if did this translate into an OS advantage? It seemed that the OS advantage was present with a OS advantage of almost about 4 months with the use of atezolizumab in the chemo-immuno backbone, in the chemo VEGF backbone. Well, does addition of bevacizumab to the whole process help in overall response rates and duration of response in liver metastasis? It seems like the combination, the ABCP regime, does well in terms of response rates. About 60% of these patients responded, as compared to only 41% patients. And as you can see, the median duration of response was also pretty high with the use of combination of atezo-bev with chemotherapy. It was about 10.7 months versus only 4.6 months when atezo was not used. Patients with bulky disease, there were a couple of indicators they used to decide which disease is bulky. One of them was patients with, when were compared with a, I'll straight away jump to this graph, when were compared with sum of longest diameter, if the size of the tumor is big, more than third quartile, it was considered to be high burden. When it was less than the third quartile, it was considered to be low burden. There was another criteria in which they took a number of metastases when more than median, they took it as high burden, and low burden was considered when the sites of metastasis was less than medium. And you can see the addition of atezo in the high and low burden, irrespective of how you calculate it, did show a benefit in the overall response rates, in the median OS, and the hazard ratio were also pretty impressive. And you can go ahead and say that the bulkier the tumor, the probably more is the response and more is the overall survival with atezolizumab than with the chemo VEGF. A little bit about the toxicity profile. The addition of atezolizumab to Bev plus chemo did show an increase in the toxicity, but these toxicities were with expected range, and they were mostly immune related. As you can see, a contrasting increase in the all grade toxicity, which were related to immune mechanisms. However, when you look closer and see the grade 3, grade 4 toxicities, they were not so much. The maximum was rash, which was like 4% in with the use of atezolizumab, and this combination of ABCP seems to be well tolerated, and there were no new safety signals identified with the use of this combination. So in summary, IMpower 150 met both its co-primary endpoints and is the first and only phase 3 trial to show a combination of chemoimmunotherapy with anti-VEGF to show a significant and clinical meaningful improvement in PFS and OS in all comers in first line in non-squamous metastatic non-small cell lung cancer. The clinically meaningful PFS and OS benefits were observed in all patients, including the key clinical subgroups such as patients with EGFR ALK mutations, such as those with liver metastasis or bulky disease. And it seems to be working in high disease burden as well. And atezolizumab in combination with chemo plus minus bevacizumab appears to be well tolerated, and its safety profile is consistent with known safety risks. Thank you so much. Over to you guys.
Thank you, Dr. Rajat.
Thank you for having me.
Just one question: where do you put your atezo in first line in your clinical practice?
I think I do it in adenocarcinoma. I tend to use atezolizumab a lot. I'm not really sure about the Bev part of it, but especially with paclitaxel carboplatin, I do use atezo. There are times when you don't get a good response, then I tend to add Bev. Otherwise, it's the chemo and the immuno backbone that I use.
Okay. Thank you. Thank you so much. So that was a wonderful talk by Dr. Ajit. And so the next session is sponsored by AstraZeneca. And I would like to invite Dr. Rahul. Sir is head of Department of Medical Oncology at Command Hospital, Chandigarh. And sir will be talking about extensive stage SLCLC, real world experience. And over to you, sir.
Thank you, Dr. Priyanshu, for a lovely gesture and for inviting me for today's talk. I request if my slides can be shared, because the slides which were sent to me were password protected without me being handed over the password. So nevertheless, it's always better to be surprised completely. So I'll probably not stick to my slides, because we've seen these slides so many times. So how I treat extensive stage small cell lung cancer, you know, over the past, I can say the past 2.5 years, I'm seeing more of small cell lung cancer than I'm seeing non-small cell lung cancer. And I think there is a paradigm shift which is slowly happening. We're slowly finding out these people who were initially smokers, and now they have developed small cell lung cancers. And what also we are getting is, we are getting non-small cell lung cancer who are moving into the small cell variety. Apart from that, what we are seeing is those neuroendocrine carcinomas, they have come up in a very, very big way. And the only way we can treat neuroendocrine carcinomas is by, I have lost my slides deck. So when I talked about talking extempore, I meant at least I should have some slides. So, right, thank you. So neuroendocrine carcinoma is one thing which has again come up in a very big way. So small cell lung cancer is there to stay. And unfortunately, we are all upstaged in India. We hardly see any limited stage small cell lung cancer. And whatever we think is limited, suddenly our radiation oncologist never feels that it is limited. So they upstage it to extensive stage, and that is how we go forward. So where are we? Next slide, please. So let me start with this case. We have a patient, 35-year-old gentleman, young individual, who complained of change in voice, slowly progressive to aphonia and dysphonia, did not have comorbidities, but had smoked all his life. He visited to the ENT, which is the first thing to do when you have a change in voice, and he was found to have a vocal cord palsy. And he underwent a CT scan of the brain, head and neck and chest. Very surprising. ENT just does the neck, but somehow this ENT surgeon did everything. And next slide, please. And we found a small, mild, enhancing soft tissue and surrounding fibrosis in the left apical segment. And that's the time the ENT surgeon referred to the oncologist. With multiple enlarged necrotic lymph nodes, left hilar, paratracheal, and paraesophageal region. Mind you, the vocal cord palsy was on the left side itself. The aortopulmonary window forming nodal mass compressing of the left pulmonary artery also was seen. Next slide, please. Yeah, so based on the CT scan, the patient was first started on ATT, and however, his condition worsened. So So patient first came to the chest physician, and as instinct it was, they start ATT as soon as they see a necrotic lymph node, not stating that even in malignancy now we get so many necrotic nodes which are there, which turn out to be malignancy later on. So patient also had an episode of seizure in September and was started on anti-epileptic drugs. Follow-up MRI brain showed, next slide please, showed that there was a 2 into 2 centimeter size marginally enhanced intraaxial lesion in the temporal lobe with multiple subcentimetric size lesions in bilateral temporal and frontal parietal occipital lobes. So basically right now a lung mass with a brain mass, patient already started on ATT without probably the tissue, without probably the diagnosis of ATT. So in India, we start ATT as soon as we get the radiological and clinical point of view. So next slide, please. So this is in 2021. And the HRCT thorax showed that the SOL in the upper left lobe with mediastinal extension and encasement, and this had increased as compared to before. So the ATT had not acted in this case. He also had mediastinal lymph nodes and consolidation in the left upper lobe. So this is the time when the physician thought that there's something else altogether. Next slide, please. And that is the time the PET scan was done. And typically the PET scan showed, apart from the lung lesion, apart from the nodes which are there, extensive involvement of there was liver involvement as well as nodes on the other side of the diaphragm which were there. Next slide, please. This is the other cuts which were seen, and as you can see, apart from the lung lesion, there are various lymph nodes which are there, and even the liver is showing few nodes, few lesions which are there. Brain, obviously, I mentioned about the lesion which was there. Next slide, please. So a biopsy was done from the lung, and it showed a small cell neuroendocrine carcinoma, and that is what I was mentioning about. The PDL1 was done, surprisingly, and the TPS score was 3 to 4% in this patient. Next slide, please. So we're dealing with an extensive stage. Why extensive? Because yes, we've got nodes on both sides of the diaphragm. Also, we've got the liver involvement, and we've got a large lung mass in upper as well as the lower lobe. The lower lobe shows consolidation plus the lesions which are there and nodes. So since the entire thing, along with the brain mets, cannot come in one radiation field, we label it as an extensive stage neuroendocrine carcinoma, also a small cell lung cancer with brain metastasis. So what do we do next? Next slide, please. So what is the next step? What is the first thing that we do? Do we start systemic therapy? Do we give chemotherapy? Do we start with chemoimmunotherapy? Well, I think the way to go forward is better to start these patients on chemoimmunotherapy. The brain radiotherapy is also an important thing. Where we do it is basically subjective, and you need to speak to your patient when to do it. If the patient is symptomatic upfront, please go for a brain radiotherapy. This patient, however, was not symptomatic upfront for the brain lesions. Next slide, please. So the treatment of brain metastasis in small cell lung cancer, decision-making amongst various people. The answer to this is, if the patient is symptomatic, please go for the radiation. Next slide, please. Yeah, so this is the NCCN guideline versions of small cell lung cancer, which shows that the extensive stage with brain metastasis when asymptomatic or symptomatic. So if the patient is symptomatic, brain RT is the way to go forward, followed by systemic treatment. Next slide, please. So chemotherapy in extensive stage small cell lung cancer, and what we've seen is that the extensive stage small cell lung cancer follows the typical Norton-Simpson's hypothesis. That is, it does respond to chemotherapy extremely well, but it comes back equally well. We've seen so many patients post 6 cycles of EP, that is etoposide and platinum, going to CR, but within 4 months, they have recurrence of symptoms once again, and the disease comes back in a big way. So therefore, the median OS of these patients is anywhere between 8 to 10 months by all these studies. So therefore, something is there which is definitely lacking in this field. Next slide, please. So our patient was started on chemotherapy with etoposide cisplatin. We were talking about 2021, where still immunotherapy in extensive stage small cell lung cancer had come, but was taking small steps. COVID was the main issue during that time. Patient also received radiotherapy, 30 grade 10 fraction whole brain with hippocampal sparing, which is the normal guidelines, and followed by 9 grade 3 fraction gross lesion, which was a boost, which was given. Next slide, please. So patient only received chemotherapy. Next slide. So, these are the preferred regimes which are there, and this is the 2023 version. As you can see, slowly and steadily, we have now shifted to the addition of immunotherapy to the chemotherapy doublet, which is there either in the form of atezolizumab or in the form of durvalumab, which is there. And these are the protocols which are there. So in 2023, if a patient comes, I think that is the way to go forward, unlike what was done in this patient in 2021. Right. Next slide, please. So this is regarding the extensive stage, and mind to remember is many times post-therapy, we find that there is some disease left still in the thorax. So apart from the whole brain RT for metastasis, consolidative thoracic RT is also very, very beneficial. The residual disease in the thorax needs to be dealt with either by surgery, which in many times is not possible. So consolidative radiotherapy has a role in case of small cell lung cancer, and it is associated with overall survival benefit. So this is very important. 30 grade 10 fraction consolidative thoracic RT, and I've given it to 2-3 of my patients, and luckily they're doing very, very well. Yes, the lung and the heart are both nearby, but with the IMRT, IGRT techniques which we have these days, I think thoracic RT is something that we should all keep in mind for our patients with residual disease in patients with extensive stage small cell lung cancers. Next slide, please. So chemoimmunotherapy. So 2021. Post 3 cycles of chemotherapy, that is the time durvalumab was added, because this is the time when immunotherapy started coming, and 1500 milligrams every month was given along with the chemotherapy. Next slide, please. So what is the rationale to add immune checkpoint inhibitors for chemotherapy? And if I start explaining you, I think half of you will fall asleep, because we've got this august audience, and what we know is chemotherapy produces new antigens, and this is on which the immunotherapy thereby acts. So they have a very symbiotic relationship which is there. The inactive T cells will get activated, the new antigens will be formed, and that is the basis of which immunotherapy works. So together they work in harmony, and that is how it works in small cell lung cancer as well. Next slide, please. Yeah, so this is the Caspian trial, and this was the first and the only approved IO regime in extensive stage small cell lung cancer, up to 6 cycles of EP in the control arm with use of cisplatin or carboplatin, which was there. We know that the trial with atezolizumab only included cisplatin and not carboplatin. So patients were randomized into the durvalumab plus EP, only EP, and durvalumab plus EP into 4 cycles, followed by maintenance as we go forward. The primary endpoint was the important overall survival, progression-free survival, ORR, OS, and PFS were the secondary endpoints. So next slide, please. Asymptomatic bone mets were included as compared to the IMpassion 133, where the PCI was allowed only in the control arm, which was there. So that is the main difference between the Caspian and the IMP 133, though we use both the drugs interchangeably in cases which are there, but this is something that we need to know, and this is very, very important. Next slide, please. So these are the salient features which were there. Durvalumab plus platinum plus etoposide 3 weekly for 4 cycles. Importantly, 4 cycles. Choice of platinum was either cisplatin or carboplatin. OS was the final endpoint. And there were 6 cycles of platinum etoposides, and optional PCI was offered only in the control arm. Asymptomatic as well as treated or stable brain met patients were included. Next slide, please. So what did the study finally show? It showed an improved progression-free survival, which was significant at 12 as well as at 24 months, vis-a-vis the other group. So definitely a progression-free survival as compared to the EP arm. And that is what we see practically also. Next slide, please. Yeah, so also improved OS benefit, which started at 12 months, continued at 18 months, was still there at 24 months. But what is most important is even at 36 months, there was almost 3 times overall survival benefit, which was seen. And this is what we want for our patients of small cell lung cancer extensive disease, to at least live for three years and probably not progress during that time period. And this is what this study showed. Next slide, please. Across all subsets, age, sex, performance status, smoking, brain, CNS mets, there was a survival benefit vis-a-vis EP. Next slide. Confirmed objective response rate was better, 67.9 versus 58 months. And this continued over a period of 24 months as we go forward. 3 times more in patients who remained responsive at 24 months. So this is something which is again very, very important. So initial responders continue to enjoy the benefit of immunotherapy, which we know is the dictum of immunotherapy. You get sustained benefit and sustained responses of the immunotherapy. Next slide, please. So the OS based on the baseline brain metastasis also showed individuals with as well as without brain metastasis both did well. Individuals with brain metastasis, without brain metastasis did much better, obviously, because their disease biology probably was not as aggressive as with the brain metastasis. But yes, there was benefit in both the subgroup, further supporting that this is the new standard of care for extensive stage lung cancer. Next slide, please. So coming back to our patients, this patient treatment received radiotherapy 18 cycles, that is including the brain and the extrathoracic, chemotherapy 3 cycles, followed by immunotherapy, chemotherapy, total of 3 cycles. Next slide, please. So what happened to our patients thereafter? As you can see, patient had a complete response. There was absolutely no disease. Even though not a complete response, he had a VGPR, which was there. Brain metastasis also gone with the help of radiation. Next slide, please. So the patient then was continued on immunotherapy maintenance, and apart from the initial 3 cycles, received another 7 more cycles, total 10 cycles of immunotherapy as maintenance. Next slide. There was further decrease in the lesions in the brain, as well as metabolically inactive minimal soft tissue thickening, which was seen in the lung, as well as the lesion near the pulmonary artery. There was no metabolically active disease elsewhere. So patient continued to be in CR, or if I can say extremely good VGPR as we go forward. Next slide, please. So coming to the fact is that immunotherapy, we know, is here to stay. So what we can do in our patients and what we should do in our patient, give them the benefit of chemotherapy for 4 cycles, and along with immunotherapy, and then keep these patients on maintenance immunotherapy so that we can keep the tumor suppressed and even keep these patients under complete check as we go forward. Next slide, please. So it is a cost. I won't go into this slide regarding the cost, because we know that probably the cost and the patient should not go hand in hand. We should stick ourselves to the overall survival and the PFS benefit. So I'll skip to the next slide. But importantly, what this slide says is the quality of life that the patient enjoy with chemo and immunotherapy is probably almost the same as chemotherapy, which is there. So something to look forward to. Next slide, please. So my last slide. Immunotherapy in the form of durvalumab has shown a sustained improvement in OS along with chemo. It's the benefit of durvalumab and EP was observed in the Caspian study. 17% of patients were surviving even after 3 years. And I know we are making further strides as we go forward with small cell lung cancer. And it offers convenient once monthly dosing regime, which is important. And it's a decent drug in our practice. Safety, side effects, everything is good. Next slide, please. Thank you very much. And sorry if I have exceeded my times.
Thank you, sir. Thank you so much. Sir, I think I would totally agree with So sir is Director Medical Oncology at Ivy Hospital, Mohali, and sir will be chairing this session, moderating this session. So over to you, sir.
Priyanshu, can you invite the panelists for me?
Yeah, sure, sir. So I'll be inviting the panelists. First is Dr. Piyush Mehta, who is a consultant medical oncologist at Sohana Super Speciality Hospital, Mohali. Dr. Kanika Sharma, associate consultant, medical oncology at Max Hospital, Mohali. Dr. Mukesh Bansal, consultant medical oncologist at Alchemist Hospital, Panchkula. Dr. Rajit Ratan, consultant medical oncologist at Ojas Hospital, Panchkula. And Dr. Deepak Singla, consultant medical oncology at Indus Hospital. And Dr. Jagdeep Singh, consultant medical oncologist at CCA, Amritsar.
So, good evening, everyone, and welcome all my panelists. You know what? We have been given half an hour, and if you finish within 20 minutes, Priyanshu is going to treat us. So, we are going to discuss about the emerging biomarkers in non-small cell lung cancer. So, why are we even discussing that? We just want to review what is the present practice and what are the interesting part will be the emerging biomarkers for IO selection. What are the other co-mutations? What are the emerging biomarkers for small molecules, especially uncommon EGFR exon 20 insertion? And just a wee bit will be touching on radiomics and emerging biomarkers for ADC selections. So, lung cancer has been an ever-evolving landscape and it is continuously evolving. So I would like to ask my first panelist, anybody can answer, what would be your essential list in the current scenario or biomarker testing in lung cancer? Non-small cell lung cancer. Yes. Anybody?
Good evening, sir. Jagdeep this side.
Yeah, Jagdeep.
So, sir, like lung, which is basically full of mutations, and even with the 2 to 3% of some of the mutations, we have a lot of targeted therapies available with us. So definitely, if a patient is affordable, will NGS panel along with the PD-L1 testing. Otherwise, a comprehensive lung panel is sufficient, for which we have the targets with us, comprising of like ROS, MET, RET, and these other like MET amplification and all these things, including with the most common, of course, EGFR, ALK, these all one.
So, and what percentage of patients are you able to send comprehensive, or you are doing a lung cancer dedicated panel NGS, or you are just doing EGFR, ALK, ROS in your patient? So what is the percentage?
The majority of the patient with the comprehensive, that is like 12 gene panel, majority I'm able to send 70 to 80% patient able to send, and along with PD-L1 testing, because we are being supported with some of the coupons from the companies.
Okay.
So majority patient I'm able to do.
No, because that is not called comprehensive. That is a lung cancer gene panel, 12 gene panel, right? Or 12 or 18 gene panel, whatever. Other panelists, please.
Good evening, sir.
Good evening.
So maybe in the frontline setting, yes, as the sir suggested, maybe the basic genes that are the EGFR, ALK, ROS, BRAF, and the PD-L1, which are the targetable. But if the patient is in, relapse setting or for second and third line, I would like to go for a complete gene panel for some changes or some additional mutations.
Complete gene panel means?
Like a comprehensive gene profile of 200.
You will go for comprehensive genomic profiling.
Genomic profile, yeah.
So what percentage of your patients go for comprehensive genomic profiling?
So, sir, upfront almost 100% we go for only that 12 or 15 gene panel only, which are the targetable mutations. In the metastatic settings, yeah, maybe 20-25% we go for those mutations also.
And that you do it through liquid biopsy or you take a fresh sample?
So we try if the tissue is available from the tissue biopsy, or if the patient is willing, so a repeat biopsy. If not, then liquid biopsy.
Fine. So my next panelist,
Good
what is
evening,
your
sir.
practice? Good evening, Jihan.
Yeah, sir. So my essential list, because of the availability of the sir, coupons sponsored by Pharma, will be the 12 gene panel by NGS. In almost all of the patients, I am able to send them. And usually, I order comprehensive testing only when post multiple lines, or in most of the patients, I am not able to send the comprehensive testing. And hurdles are mainly the availability of the tissue. So tissue is a big issue basically in non-small cell lung cancer. So that will be my.
Okay, it's the hurdle is only the tissue.
Sir, other hurdles are there. The financial hurdles are obviously there.
Okay.
But apart from that, tissue is a big hurdle.
Wow. So, do all of you think, who's left? Rajit has left. Do you think, Rajit, our practice is going to change? This is written in the past 24 months. I would say in the coming 24 months, is our practice going to change?
Sir, I believe we will see more number of mutations being covered in our so-called lung panel test, and because eventually we will have more drugs available for first line, which obviously the trials will be coming for first line therapies, and there will be more drug availability for us to target. My approach
Okay.
is very simple in this, sir. I see if what are the reasons that preclude me from starting chemoimmunotherapy, and if I see there are few those tumor biomarkers I use which preclude me from using chemoimmunotherapy, I may not actually go for a MET amplification or a RET. I'll
Okay.
probably EGFR, AL cross, BRAF, because I know.
Okay. But given a chance, you would like to send these markers, no?
Yes, definitely.
Definitely, right. Fine. So, 2013 guideline recommendation by CAP, IACLC, AMP established testing guidance for EGFR and ALK gene fusion. 2018 added ROS1. Soon thereafter, BRAF testing was included. BRAF testing was somewhere in, when the COVID was nearing. And in most recent situation, you have EGFR, ALK cross, BRAF, MET exon 14, RET, ERBB, NTRK, and PDL1. And current recommended testing modalities, I say these 10 target is quite varied, ranging from molecular or PCR or FISH, IHC, NGS, and or gene fusion assay. So these are the NCCN guideline. Here, the important thing to see here is not only the marker you are testing, but also, you see, for the routine EGFR exon 19 and 21 mutations, you have a different set of therapies. And for uncommon EGFR mutations, you have different set of first-line therapies. And for EGFR exon 20 insertion, we have different therapies. And so we have come a long way. When there was a time when it was only EGFR amplification, based on which we used to start Jeftinib or Erlotinib for that matter. Now it is these specific mutations, and we are targeting specific mutations. These things are going to come up, I think, subsequently in ALK also, and also in all these types of treatment, there will be a sequential usage of agents. So first line may subsequently change in some of the genetic alterations. So yes, this was the question I asked to Kanika, and Mukesh, and got a varied results. So rest of the panelists, what percentage of your patient go for comprehensive genomic profiling test? Hello.
Yes, sir. Good evening, sir.
Deepak.
Deepak
Yeah,
this side.
Deepak,
This side,
yes.
sir. Sir, I always encourage all of my patients to go comprehensive. Generally, this is my practice to do the comprehensive gene profiling on the first setting only, because because of the tissue constraint whenever they metastatic, and because for the further testing it may not be available. So my practice is to do the CGP on the baseline. As now these days NGS is very much covered by the majority of my patients are impaneled patient, so they don't have a much issue if we write them, if we get the permission and write the logic that why they are requiring. So I think most of the them they are approving it, but if in due to any reason if they are not getting the permission, so at least these basic 10 to 12 mutations we should be doing it.
Okay. So you say that you in 90% of cases you upfront send comprehensive genomic profiling. Where do you
Yes.
send these CGP? Is it mainly Indian-based labs or
Yes. It varies person to person. When I was in Gurugram, so there we used to send to Foundation One as well. Now here is the majority of them they are going to the Indian labs only. Like we are having a MOU with this Positive Biosciences. And even in Delhi NCR also we used to send them if somebody is not affordable for the Foundation One, then it was going to the this Positive Biosciences. Here also we are having MOU. So
Okay.
sometime if we get the permission, then we are tend to send.
You tend to send. And what is the time? What is the tag for the reports to come? And in the meanwhile, what do you do for the patient?
No,
For
actually, sir,
CGP.
the TAT is, sir, it is less than 2 weeks. Majority of the time, it is less
For
than 2 weeks.
CGP.
Yes, sir. I mean, within 2 weeks, it is coming, sir. Even within 2 weeks, it is coming.
That's interesting. Which lab is giving TAT in less than 2 weeks? Anybody, rest of the panelists, if you are sending comprehensive genomic profiling, when are you getting the results? Kanika?
So mostly around 3 weeks they take actually.
Yes.
It is 21 working days.
Well, yeah.
It's 21 working days, so it takes about a month.
Sir, that's right, sir. I mean, that's right. But even when I used to send to Foundation One also,
Okay.
I used to get an email by by the starting of third week. So but actually they within 2 weeks, their majority, I mean, they are reporting like 2 and 2.5 weeks, they are reporting it.
Okay. So my experience has been different.
Can we give your rep for our patients also?
Yeah, sure. Why not? Why not? But you have to be just after them. You have to be just after them. I mean,
okay.
Yeah. And
Interesting.
meanwhile, we will start, sir, depending on the condition of the patient, and I generally start with the cytotoxic chemotherapy plus minus IO.
Okay.
Yeah.
So IO you start before the CGP test come?
CGP.
Before
Sir,
CGP,
generally,
are we justified in starting IO?
yes, sir. Why not, sir?
Okay.
No, why not, sir? Even if the PDL one is
So
negative
we
one second,
come
sir.
to
If the PDL one is also negative, we can start the IO, sir. There is no, I mean,
no. See, if there are targetable mutations, then will IO work in that?
Sir, okay. Yeah, I mean, that is also true, sir. But
Okay. So anyways, we come to that further. Okay. Okay. So anyway, so even cell-free DNA has been used, or liquid biopsy has been used, especially. And sometimes what has happened is, if from the what practically has happened to me, that from the solid tumor block, when I have sent the test and it has been done with not with the NGS, it has been done with PCR and various other techniques. Sometimes I miss the important mutation. Recently, I had one patient. So since patient is not willing for a repeat biopsy, we have sent it through liquid biopsy also, and we got a EGFR exon 19 deletion in liquid biopsy. So yes, tissue versus first cell-free DNA first approach to the evaluation of 8 guideline recommended biomarkers reported a detection rate of 67% versus 87%. So liquid biopsy is more sensitive, but only and only if there is a actionable marker in that liquid biopsy. And if you do both, that is, if you do liquid biopsy along with the tissue, then in either cases, the yield increased to 33% in the tissue biopsy and 13% in the liquid biopsy. So in liquid biopsy, you tend to get more number of positive results, especially if there are a targetable mutation present. So yes, it can be an interesting option. And I think in the Western countries, they are sending both. And also they say that with liquid biopsy, you tend to get a result a bit rapidly. So liquid biopsy provides a convenient and promising option for molecular profiling in patient with NSCLC. Its usefulness primarily is limited to cases in which a targetable mutation is detected. Whereas the result, yes.
So the concordance between the liquid and tissue biopsy is close to 65 to 70%. I
Okay.
think the patient who has a disease progression. So as you rightly said, if actionable mutation was initially present and you develop some resistance, it will be a better choice to go for a liquid biopsy rather than going for a tissue-based biopsy.
Agreed, totally agreed. But this was the study, Jagdeep, in the first line setting, which they have mentioned. So, but you rightly said that if there is a actionable mutation, you have more chances of getting yield out of liquid biopsy compared to tissue biopsy. So gaps in biomarker testing, like our country, even US has issues. And as you can say, in MyLung Consortium molecular testing between 18 to 20, all 5 biomarker tests in non-squamous were done in 49% of cases. And overall, it was 46% of cases, while NGS was at that time done in 37% and 39% respectively. And if you go with the Flatitron data, the with routine testing technique, yes, there were plenty, around 80 to 86% of patients getting tested. But NGS actually picked up after 1 year of therapy. So now this is the question. What is this rapid NGS? Is it a feasible solution in your setup? Yes, Deepak, I think you are the right person to answer this question. You said you get the mutation within 2 weeks. So what is rapid NGS?
No, for me, 2 weeks is quite okay, sir. I mean, there is not much of urgency. I mean, beyond that, if they are reporting in 2 weeks, that's sufficient enough. I mean, rapid NGS, I'm not aware of that. How rapid they can do that?
Yeah, they produce the results within 72 hours also. So yes, 2 weeks is sufficient for us also. But yes, in rapid NGS, this is ultra fast next generation approach as a reflex testing. So anybody is aware of this rapid NGS? Rest of my panelists, Mukesh?
No, sir. Sorry, I'm not aware of this rapid NGS.
Sir, in India, which lab is doing, sir, this rapid NGS?
None.
None. Okay. Rapid biopsy report, I have heard that histopath they can give in 24 hours. In Jalandhar, they are doing it, but I'm not aware of this rapid NGS.
Okay. So, and in your institution, do you integrate IHC or PCR with NGS study, or you either do an NGS or do an rest of the studies? Rajit?
So I remember having one patient who had a significant burden of disease on presentation, and we had a biopsy specimen.
Hmm.
And, we discussed because and we wanted to do something. She was not perfectly suitable candidate for therapy, and we were hoping we would get a tumor sort of some mutation that we can give her. She was I think comatose, and we could have given her something by the rise tube actually, and
Hmm.
therapy was indicated. We did sort of discuss the idea of doing an IHC and PCR based assays because their downtime is pretty less. You get the report in 2-3 days, whereas for NGS you'll have to wait for 2 weeks, and then the patient may not actually be alive till then. So
Okay.
I had only one patient. I did.
And did you get the mutation?
No, we did not, and it turned out to be a futile exercise. It didn't last.
Okay. Okay.
But I
So, so either of the technique you're using in the institution, I mean, either we straight away go for NGS or in people with constraints, cost constraints of not using the therapy and
Sir,
all.
actually, I sometimes follow this in the patients who are like female non-smokers, and in which I tend to believe that these mutations might come positive. So with biopsy only, I send EGFR and ALK so that I can start these targeted mutation because the NGS take around 3 weeks of time. So
Right.
in those cases, I do send.
So initially, then is your tissue saved? I mean, because they tend to exhaust the tissue. First they do IHC and then they do
So we
EGFR.
usually tell them to use just for those tests, or if the tissue is sufficient, then we have done, and one of them have come out to be ALK positive also. So in
So
those
I feel,
cases,
sir, in case of Sanger, if I'm not wrong, so the tissue enrichment is very important, which is not required in NGS. So if the tissue enrichment you do and you are already exhausted, then it will be a problem for us to go for the next test.
Yes, if you are not having a viable tumor cell in the tissue left, then I think sending an NGS, or you can send a liquid biopsy at that time if you get a target. If you get a target in these, can you send a liquid biopsy at that time? Liquid biopsy NGS. I think that can be a viable option.
yes, sir, since these are actually mutually exclusive, so we can send liquid biopsy.
We can send liquid biopsies. Yeah.
Sir, one question, sir. One question,
Yeah.
sir. Sir, is IHC is mandatory?
Not really.
So, I mean, why
Yes,
to
it
waste
is
the
mandatory
tissue?
for PDL1 testing.
No. I mean to say, okay, PDL1 testing is fine, sir. In order to differentiate whether it is a squamous or whether it is
Yes,
adenocarcinoma.
it is not.
No,
We don't
not.
consider it mandatory, but our pathologists consider it as mandatory.
If a good pathologist label that it's a squamous or it's adeno, it has to be taken as that.
Yes,
Yes, that's
exactly.
right.
But the thing
That's right.
is, in most of the institutions, what they do is they do a basic IHC. They don't label it very clearly. Possibly, likely, all this stuff has been used in the reports. So let's see about IO selection. This is a patient, 59-year-old gentleman, evaluated for complaint of backache, 4 months duration. MRI spine revealed multiple lesions, skeletal lesion. PET CT showed skeletal upper mass and pleural nodules. So metastatic adenocarcinoma lung, CT guided lung biopsy, PCR studies on the tissue was done. No actionable mutation was found. So liquid biopsy NGS was sent and it was found to have TP53 mutations. Somehow they did an IHC of PDL1 and that was TPS 10%. So what will be your choice of treatment? Yes, one by one. Who's sitting first? Yes, Jagdeep, let's start from you.
So, sir, for patient presented with TPS of 10% and no other actionable mutation. So in this patient, I will be comfortable to start with the combination of chemo plus IO with the pembrolizumab in this patient.
Okay. Rest of the panelists, I'll be really fast about it. Rest of the panelists agree to it?
Yes, sir.
Yes, sir.
Yeah,
I may have a difference in opinion, sir.
right.
We do not have a NGS for actionable mutations
Yeah.
on the biopsy.
We had on a liquid biopsy.
Yeah, so I may
We
probably
had a liquid biopsy.
The PCR studies are there. It is mentioned that PCR studies are there and there is no actionable mutations. So might be they have checked all the.
Okay.
So this is what I infer from this, I think.
Yeah, that's what I also infer. Yes, anybody else has anything to say on this? Priyanshu, do you have anything to say on this? Priyanshu, are you there? Okay. Or you're logged off? So what do you think in this case? Are you comfortable in starting IO? Deepak is comfortable.
Yes, sir.
Hmm?
Yes, sir. There's no.
Your voice is suppressed. Your wife is around?
Yes, sir. Can you hear me now?
Yeah, that's better.
Yeah. So I think so, sir. Liquid biopsy alone would miss, probably some 8%, 7 to 8%.
Okay.
And
So do you
uh,
think in this case, is it safer starting immunotherapy or not?
yes, if there's no other options, so definitely we can start. But I would still prefer if we have a NGS on the tissue sample.
Right, right. Okay. Okay, so TP53 is an important marker and the mutation rate is around 39 to 46% in adeno, 81% in squamous, and 68% in large cell carcinomas. And Dong et al. Performed an integrated analysis on multi-dimensional data types and reported that mutation of TP53 and KRAS actually increased the expression of PDL1 and infiltration by CD8 plus T cells. And TP53 KRAS co-mutated subgroup manifested exclusively increased expression of PDL1. So if you have a double whammy TP53 KRAS, it's even better and have more sensitivity to immunotherapy. So these are the various markers, and ICIs are effective. This is after comprehensive genomic profiling. If PDL1 is high, TMB, tumor mutation burden is high, if there are more tumor infiltrating lymphocytes, if MSI is high or deficient MMR is there, if there are DNA damage repair genes, if there are KRAS mutation, if there are TP53 mutation, ICIs are more effective in such kind of genetic setting. And ICIs don't have much effect if there is EGFR ALK, JAK1, 2, P10, STK11, LKB1. Though Javed ji showed that if STK11 is mutated, it Nivo-IP actually worked, while STK11 wild type it didn't work. But STK11 usually is associated with co-mutation. MET exon 14 mutation B2M. I don't know about this mutation. And there is a chance of hyper progressive disease if you use ICIs. This is a very important thing, very important concept, that if you have MDM24, if you have DNMT3A, if you have CDKNA2A oblique B, MDMT24, EGFR gene mutation, sometimes there are certain gene mutations which are really bad, 11q13 sites mutation. These are genes which make hyperprogression a reality if you use ICI. And I was just going through hyperprogression, it's a very interesting topic. And the Chinese have come up with a very interesting and a low cost nomogram, though it is a retrospective study, in which they identified 3 lab parameters. One was LDH, other was MCHC, and the third was ESR. And they formed a nomogram that on the basis of that, if LDH is high, MCHC is low, and ESR is high, and then the efficacy of ICI is not only low, but also they tend to have more of hyperprogression disease. This was a very interesting paper, and I think each of us should also have such kind of a study in our country, where each and every one is not able to send comprehensive genomic profiling, because if there is a hyperprogression, your patient is doomed. Any clinical phenotype that predict for IO resistant? So yes, so let's come to the clinic. So yes, Deepak, any clinical subtype of lung cancer in which you say ki is, if I use IO, it will be hyper progressive?
Hyperprogressive. Sir, I cannot say.
You cannot say. Anybody else?
I cannot, because
Mukesh?
it has never happened to none of my patient.
Let's see, what are the hyperprogression rates? What are the hyperprogression rates in your clinic?
I have not come across any hyperprogression.
You have not come across any hyperprogression?
No. Still now, by God grace, it is not there.
Okay. So, Mukesh?
Sir, with use of IO, you are saying hyperprogression?
Yes, with use of IO.
Sir, no, that I know. Maybe in 1 or 2 cases I can, but because all the testing couldn't take place, 1 or 2 patients didn't come or deteriorated. But I didn't test, the scanning was not done, so I can't say, but there is a possibility in 1 or 2 cases where I encountered some
So any clinical scenario, anything you remember about the clinical or radiological picture of such patients which leads to hyperprogression?
Sir, it was like other patients only, nothing different which I can remember. There were typical cases only.
Right. So the second question I have already asked you, are you comfortable to proceed to IO without NGS results?
No, sir.
Right. So one should not proceed with IO without NGS result. That should be the dictum. So HPD is also known as toxic response, may occur in 10 to 16% of patients with NSCLC. The clinical characteristics are age more than 65, number of baseline metastatic site more than 2, or local recurrence. They are quite inconsistent, they say, but these are the genetic markers which they say are strongly correlated with HPD. KRAS mutation, yes, IO has an activity in KRAS mutation. So this is one targetable mutation in which you have an activity in KRAS in mutated subtype. So I think I would skip the rest of it because we are crossing the time. Priyanshu?
We have 3-4 minutes, sir.
3-4 minutes. Okay. So let's come to EGFR uncommon mutations. So major uncommon mutation are G7919X, L861Q, 76681, compound mutation, exon 20 insertion, T790M, and other. So exon 20 is not that uncommon mutation among the EGFR mutation. As we all know, around 12% of cases have exon 20 insertion mutation, and for the combined post hoc analysis of Lux Lung 2, Lux Lung 3, and Lux Lung 6 clinical study is currently the largest prospective study on efficacy of EGFR TKI in patient harboring uncommon EGFR mutation. Of the 600 patients given afatinib across these 3 trials, 12% had uncommon and 71% in group 1 had the group 1 was point mutations or duplication in exon 18 and 21. Group 2 is de novo T790M mutation in exon 20 alone or in combination with other mutation, and group 3 is exon 20 insertion. And these were the various median PFS. So afatinib is actually a very good drug against uncommon mutation, but specifically for EGFR exon 20 insertion. Is PCR a right modality to check for exon 20 insertion? Fast, anybody?
So, sir, maybe if we miss the for exon can be there, but if some sort of introns are there, RNA-based NGS can be the better option.
Yes, we can miss exon 20 insertion on PCR. So for exon 20 insertion, to rule out exon 20 insertion, you should have an NGS. And what would you prefer if amivantinib is not available in exon 20 insertion?
Chemotherapy will be the drug of choice for that patient.
Perfect. But people have used all kind of things. People have used afatinib. People have used osimertinib also. Patient with exon 20 insertion treated with afatinib had an ORR of less than 10% and median PFS of 2.7 months. And there was one regime called afatinib plus cetuximab. Some people have used and found some interesting data. Amivantinib is a bispecific EGFR MET receptor antibody, very important to treat such mutation. And Chrysalis was a study in which there was a ORR of 40%, clinical benefit rate of 74%, duration of response 11.1, unprecedented, median OS of 23 months. Otherwise, so these are the various efficacies of EGFR exon 20 targeted therapies. Radiomics is an AI-based technology in which you can predict with the radiologic parameters that your patient might be harboring
Dr.
some.
Jatin requests you to conclude.
Yeah, I think I wanted to conclude, so I'm not going into the detail of HER2. Sorry, actually, it was too long a topic to discuss. So thank you, and thank you all my panelists for the inputs. Thank you, Priyanshu, once again.
Thank you, sir. Thank you, sir, for such a detailed discussion.
Thank you, sir.
And thank you to all the esteemed panelists. So we now move on to the next session that is sponsored by AstraZeneca. For that, I would like to invite Dr. Sandeep Pukkar, who is Director Medical Oncology at Sohana Super Speciality Hospital, Mohali. And sir will be speaking on effective sequencing strategies for EGFR mutated and non-small cell lung cancer patients. So over to you, sir.
I just want to know how to stop screen share.
Sir, I have stopped screen share.
You
can now
stopped?
share the screen. Yeah.
Okay, thank you. Thank you.
Good evening, everyone, and thank you, Priyanshu, for providing the platform for discussing today's topic on Tagrisso. I think time and again we have discussed about what is the first line treatment for EGFR positive mutant metastatic NSCLC. So let's revise it once again. So somebody from the organizers can share the slides.
Sure, sir.
So we all know that osimertinib has been on the frontline treatment, whether you take it as a metastatic setting or now with the upcoming use in the LAURA study as well. Maybe post CTRT will have another option in the adjuvant settings, you can say. Next slide, please. So there has been a debate about the use of EGFR, that is osimertinib in the frontline, or followed by the use of a first line or second line TKIs, followed by third generation TKIs, that is osimertinib. Second strategy could be the use of EGFR TKIs with anti-angiogenesis agents. like the trial we had from Tata, followed by when the patient progresses, depending on the mutation status of T790, you can select the agent appropriately. Next slide, please. So these are the sequencing options, whether you can use first line, whether you can use first generation, you can use second generation, you can use the combination strategy, or you can use only osimertinib in the frontline settings. Next slide, please. So this is about what we have from in terms of overall response rate, progression-free survival, and the median overall survival. You can see, as we all know from the FLORA data, it has provided a very robust overall response rates to the tune of around 80%. Progression-free survival that once was considered as the overall survival, that is approximately 1.5 years of progression-free survival and approximately more than 3 years of overall survival with the use of osimertinib. As compared to other frontline, first line, and second line, none of the agents could achieve such a remarkable overall response rate, progression-free survival, and the overall survival. Next slide, please. So this is the highlight. This is the highlight of the FLORA study. One, it included exon 19, L858R. Two, it included the stable CNS mets, and it compared it with a very robust then standard of care, that is gefitinib against osimertinib 1:1. The primary endpoint was the progression-free survival. The other secondary endpoints were overall survival. Mind you, in a metastatic setting, progression-free survival is important, but here again, it is important to highlight that majority of the patients, once they are on a drug and they have a crossover of the drug, it is important that you look at the overall survival, because we have seen with the other trials, once the agent gets crossed over to the newer agent that we are comparing, the overall survival benefit is not there. But we'll show in the coming slides that why it is important, why this trial is of utmost importance to highlight is, even though there was a crossover, patient had an overall survival benefit with a very good hazard ratio. Next slide, please. So this is about the progression-free survival, all the subgroups which can be hypothesis generating. But if you look at the patients who had CNS metastasis versus the patients who did not have, and secondly, you compare whether it is exon 19 or L858R, the subgroup analysis clearly shows that it is favoring the osimertinib arm, almost doubling of the progression-free survival, that is 19 months against 10 months. Next slide, please. So this has again translated into the overall survival as well. And secondly, if you look at the comparison of the separation of the curves with Lux Lung, afatinib, Archer 1050 versus the FLORA study, right from the very beginning, you have the improvement in the response that translates into the improvement in the response rates, that is separation of the Kaplan-Meier curves. So that is why you have a very robust response rates compared to dacometinib and the afatinib. Next slide, please. So again, important to highlight is the Archer 1050 did not include the brain metastatic patients as compared to the FLORA study. So the patients who are on osimertinib, the time to the subsequent treatment is also improved. In fact, it is doubled if you see 26 months versus the 13 months. So your time to subsequent treatment is also increased. Next slide, please. So this is about the overall survival. It is one of the first EGFR TKIs that has shown the transformation of a progression-free survival into a significant overall survival benefit beyond 3 years. And the point to highlight, the point to ponder upon is there was a crossover rate of around 31%, which was observed in patients who were assigned to the comparator arm. Even though there was a crossover, still the study managed to prove an overall survival benefit. Next slide, please. So how about the sequencing strategy that we have been discussing about, whether it is dacometinib followed by osimertinib or whether it is Lux Lung, afatinib followed by the osimertinib? In fact, in patients with the Archer 1050, 10% of the patients who received osimertinib, 10% of the patient in the dacometinib arm, they received osimertinib for T790M. Again, for patients, those who actually progress, approximately 40% of the patients will have a T790M and they will eventually receive osimertinib. But I'll again highlight this important point that once you have a disease progression, some of the patients might not be eligible for such a superior or such a robust treatment arm, which you are depriving if you are not using the agent in the front line. So here in the sequencing strategy, the overall survival benefit that could be achieved was 34 months compared to what we had seen with the FLORA data, that is beyond 3 years. So majority of the patients, around 1/3 of the patients or 1/4 of the patients would be on osimertinib despite the on therapy for approximately 3 years. Next slide, please. So this is again important to highlight. So the dacometinib could not prove the overall survival benefit. Why? Because the trial design was such that overall survival benefit could be analyzed only if there was a statistical significant improvement in the overall response rate. So that was the key endpoint. So that is why there was no difference between the two arms for overall response rate. So that is why dacometinib was never tested for improvement in the overall survival benefit. There was a numerical improvement, but again, the p-value was not that significant. You can see the crossover in the overall survival curves. Next slide, please. So again, this article was published in the Current Oncology in 2020, and as we have seen in the earlier slides, that there was a numerical improvement in the overall survival, 34 months versus 28 months. But again, the trial was not meant to look for that overall survival benefit. Why? Because it was a hierarchical stratified statistical design, which was on the front line. It was tested for overall response rate. So once the response rate was not there, it was not tested for OS. Next slide, please. So this is about the subgroup analysis. Again, there is a flip between the PFS and the OS curves. If you look at the Asian versus non-Asian, and if you look at the exon 19 versus the L858R, so you can see the PFS and the OS curves, they are not matching, but still, I think the sequencing strategies might be justified if there are financial constraints and the patient might not be affordable for osimertinib. Only then. But if you look at the data, I think it states something else. If you look at the Asian versus the non-Asian, exon 19 versus L858R, if you have a PFS benefit, it does not translate into an overall survival benefit. And if you have the OS benefit, it does not have that sort of PFS benefit. That robust PFS benefit is not there. So that is why some sort of flip is there in between the PFS and the OS curves. Next slide, please. So this should be taken with a pinch of salt, that the subgroup analysis could be hypothesis generating, but again, you cannot conclude anything out of it. So this is about the sequencing strategy and the overall survival from the LUX-Lung study, and the exon 19 subgroup analysis. That is, the maximum could be achieved was 30.7 months. But there is a conflict. Why the sequencing strategy came into highlight was we had a retrospective analysis where overall survival and was the exploratory endpoint, where I'm talking about the famous GeoTag study, which showed an overall survival benefit of around 41 months, which is again, I believe it is very difficult to achieve with the use of afatinib followed by osimertinib. Next slide, please. So this is about what we were highlighting earlier, that 7 out of 10 patients who start on a first generation or second generation will not be able to receive osimertinib. Why? Because majority of the patient in the front line, they will receive only the palliative care. Some of the patients you might not be able to even test, because nowadays we have a liquid biopsy, but still the test results might not be available. So out of 10 patients, if you see 3 are eligible for second line osimertinib, or maybe 4 are eligible for second line osimertinib. So you are depriving at least 30 to 40% of the patients who might be eligible candidates only in the front line. And secondly, you might not even know which patients are going to develop T790M. We do not have a marker for it, that these are the histopathological types where you can expect a T790M mutations in future. Next slide, please. So this is from the real world studies about T790M. As I have already stated, there are Japanese and the Taiwanese studies which state that around 40 to 50% of the patients will be eligible for T790, will be harboring a T790M mutation. Although the data is a bit extrapolated, I would say in whatever patients I have tested, I think the T790 existence is approximately 15-20%. It's not more than that. So again, very difficult to say because of my limited experience, but still, if you look at the data, it states around 30 to 40% of the patient would be harboring a T790M mutation. Next slide, please. So this is about the famous GeoTag study, which was, again, it was not a phase 3 study. It was a retrospective observational analysis, and it excluded patients who were T790M negative, who died in the first line, who could not receive a second line therapy. So these are the excluding factors, and geotag endpoints were you cannot compare time to treatment failure with the progression-free survival benefit. So geotag patients had a higher incidence of DEL19, where we all know that DEL19, exon DEL19 are the patients who tend to do better compared to other subgroup of the exon deletions from 19 to 21. So this is that is why it is not possible to draw conclusions about the relative benefit of using osimertinib in the frontline versus the sequencing strategy afatinib followed by the osimertinib. Next slide, please. So this is about what we were discussing earlier, that from the data from various trials, Archer, Lux lung studies, and various other trials, that there are what percentage of the patients would be eligible for osimertinib after the use of first generation or second generation TKIs. So variable results are there, but approximately 10 to 20% of the patients, they go on to receive the second line treatment as compared to if you started in the front line. Next slide, please. So this is about 31% patient in the osimertinib arm, 30% of the patient in the EGFR TKI comparator arm did not go to receive any form of subsequent therapies in anti-cancer therapy in FLORA study. So again, you need to send your best batsman first in the front line so that you can achieve an excellent overall survival benefit if you want to make your patient have to live longer in terms of using TKIs in the front line. Next slide, please. So this is how whether to sequence or not. So important highlighting points: T790M mutation post first line therapy, it cannot be predicted. Not all patients would be eligible for second line and subsequent lines of therapy. Osimertinib is the only TKI to reveal a statistically and clinically meaningful overall survival benefit. PFS and OS curves, they clearly show that all the subgroups, they were benefited with the user, whether it is Asian, whether it is the brain metastasis or not, all the subgroups were benefited with the use of osimertinib. It is a safe and well tolerated and good toxicity profile. Sending your best batsman first would make the optimal sequencing strategy if you are looking at the overall survival. Next slide, please. So this is all I have from my side. If there are any questions, I'll be happy to answer. And I thank again the organizers for having me here tonight. Thank you.
Thank you, sir. Thank you so much.
Is there any questions, sir? Okay, so now move on. I would like to invite Dr. Priyanshu Chaudhary, sir. He's a consultant medical oncology, IV Hospital, Mohali. And this session sponsored by Pfizer. And topic is time to raise the bar for ALK positive NSCLC. It's over to you, sir.
So thank you for the introduction, and thanks for Pfizer. So next slide. So my topic today is time to raise the bar for ALK positive metastatic NSCLC. So this is the timeline for development of ALK inhibitors. So one of the fastest, I would say, in the history of oncology. In 2007, the EML4 ALK translocation was discovered, and within 5 years we had the first generation ALK inhibitors approved. That is crizotinib. Then the second generations came in 2015. Ceritinib, alectinib, and brigatinib, and the third generation lorlatinib was approved in 2019. Next slide. So what are the unmet need in the ALK positive NSCLC? So if we look at the ALK positive NSCLC patients, they are generally young. The median age is younger compared to like around 51 years, and they're non-smokers or light smokers. And they have a lot of CNS metastasis, around 20 to 40%, which leads to their poor prognosis and CNS relapses. So treatment challenges, even with the availability of second generation ALK TKIs, are the ALK resistance mutations, the CNS metastasis, that is inadequate penetration, then durable control of brain metastasis in patient with brain metastasis, and preventing brain metastasis in those who have not had them at the baseline. And there is a need for additional ALK TKI that prevent the emergence of resistant subclones in untreated patients. Next. So, if it wasn't hard enough to choose one agent first line, so we have a lot of agents available now. So, what is the overall efficacy, the overall survival? What's available second line? What's the CNS activity and response rate and progression-free survival? Next slide. So, we'll be discussing the phase 3 CROWN trial of first line lorlatinib and ALK-positive metastatic NSCLC. Next. So, this was the study design. It included patients who had a stage 3B to 4 ALK-positive non-small cell lung cancer without any prior systemic treatment for metastatic disease and an ECOG performance status of 0 to 2. Patient should have had an asymptomatic treated or untreated CNS metastasis. They were permitted, and with one or more extracranial measurable target lesion with no prior radiation was required. So they were randomized to lorlatinib 100 milligram per day in a single dose versus quizartinib 250 milligram twice a day. And they were also stratified by presence of brain metastasis and ethnicity. The primary endpoint was PFS by BICR. Secondary endpoint were investigator-assessed PFS, ORR, intracranial ORR, intracranial time to progression, overall survival, safety, and quality of life, and no crossover between treatment arms was permitted. Next slide. So looking at the primary endpoint, that was BICR assessed PFS. So if we look at the graphs are separating beautifully. The 18 months data again showed median PFS was not evaluable versus 9.3. Again, in the 36 months data, again, intention to treat population, if we see, even at 36 months, 63.5% of the patients were progression free, and the median PFS has not yet been reached. And if you look at the hazard ratio again, and very impressive hazard ratio of 0.27. Next. So again, depending upon whether the patient had brain metastasis or not, we have the PFS curves here. So they are both, if we see patient who had a baseline brain metastasis as well as those without brain metastasis at baseline, the curves are separating beautifully. Quizartinib is faring very poorly in patient with baseline brain metastasis. If you see the rapid fall in the Kaplan-Meier curve with quizartinib. So the median PFS was not reached in both the subtypes, both the types. The hazard ratio again very good, 0.21 in patient with brain metastasis and 0.29 in patient without brain metastasis. So again, we have a very good intracranial responses, and even at 36 months, you see the median intracranial PFS has not been reached. Next. So if we see, this is the comparison between the CROWN ALTA-1 and ALEX studies. So if we see CROWN utilized lorlatinib, ALTA, brigatinib, and ALEX alectinib. So the median follow-up period is quite similar if we see, and sorry. So the PFS rate at 12%, PFS rate at 24 months and 36 months again is better with lorlatinib compared to the other two TKIs. Again, the median PFS was not reached with lorlatinib compared to 9.3 in quizartinib and 24 months with brigatinib and 25.7 with alectinib. And if you look at the hazard ratio again, they are very similar between brigatinib and alectinib, but very impressive 0.27 with lorlatinib and the CROWN trial. Next. Again, this is all the cross trial comparisons have limitations. So we are comparing here the hazard ratios, both the BICR and the investigator assessed. So if we see again, most of the studies, crizotinib, ceritinib, brigatinib, alectinib, and ensartinib. So the hazard ratios are somewhere between 0.45 to 0.55. But here lies the difference when we come to lorlatinib. It is again a significant 0.21 investigator assist and 0.28 with the BICR. Next. So these are again the 1 to 3 year data and 4-year progression-free survival estimates Again, lorlatinib is still not reached the 50% mark here with the 4-year, while alectinib and brigatinib data are numerically inferior. Next slide. So again, now coming to the time to intracranial progression in the intention to treat population, if we see the time to intracranial progression was significantly longer with lorlatinib than with crizotinib, and there were only 9 events in the lorlatinib arm, and the 3-year intracranial progression free percentage were 92.3%, very impressive, compared to only 37.7 versus in the crizotinib arm. So the time to the hazard ratio here is a very impressive 0.08 for intracranial progression free survival with lorlatinib. Next. Again, the BICR assessed intracranial time to progression again, significantly prolonged. The median PFS was not reached in patient with baseline brain metastasis versus 7.3 with crizotinib. Again, 73% of the patient were free from intracranial disease at the end of 3 years. Only 8 events and a hazard ratio, again, a very impressive 0.10. Next slide. So the CNS efficacy of first-line lorlatinib, again, the intracranial responses in patient with baseline measurable brain metastasis. You can see the plot, waterfall plot here, beautiful, just one progression, and there are a lot of complete responses here and a few of partial responses too. So compared to Alex, there were 72% complete responses versus 38% in Alex in patient with measurable baseline brain metastasis. So again, a very significant intracranial efficacy compared to the other second generation TKIs. Next. So again, a BICR assessed intracranial time to progression, median PFS not reached versus 30.8 months, a hazard ratio of 0.02, which is almost unheard of in oncology. There was only one event, 1 out of 112 patients without baseline brain metastasis exhibited intracranial progression all lorlatinib, and a 3-year intracranial progression free percentage is 99%. So this is very impressive data. Next. This is a summary of efficacy. The median PFS, is again not reached versus crizotinib around 9.3 months and a hazard ratio 0.27. Alectinib it is 25.7 versus 10.4. Again, now PFS in patient with brain metastasis, that ratio is 0.21 versus 0.40 with alectinib. And PFS in patient without brain metastasis, again, a hazard ratio 0.29 versus 0.51 with alectinib. Time to CNS progression, again, hazard ratio 0.08 versus 0.16. And intracranial response rates 83% with lorlatinib versus 81% alectinib. But the CR rates are almost double, 72% versus 38%. Next slide. Now, this is again a very interesting data. This is the updated analysis from the CROWN trial. So we are moving from ALK being a single entity to ALK having different variants who have different responses. So the EMLA 1, 2, 3 variants have been recorded, which have clinical differences. The ALK variant 3 has shown to be the one with the least responses to TKI, and if we see here in this curve with the crizotinib, it has shown a median PFS of only 5.5 months, and compared to not reached and 7.4 in the other 2 variants. So similarly, lorlatinib, the median PFS is not reached in variant 1 and 2 versus 33.3 months with the third variant. Next slide. So although lorlatinib has reached 33 months, but compared to other 2 variants, it's still less, but still compared to the other TKI that is doing very well, even in this EMLA ALK3 variant. So median, if we look at here, there's a solid bars are for variant 1 and the dashed one are for the variant 3. So the median PFS was not reached for variant 1 in the lorlatinib arm and was 7.4 months in the crizotinib arm. Again, the median PFS in the variant 3 was 33 months versus 5.5 months respectively. Next slide. So again, this is across the other two trials that along with Crown, that is Alex and Alta 1. So if we see the green one are the variant 1 and the red one are the variant 3. So the lorlatinib in the variant 3 is 33.3 months PFS, drops down to 17.7 months with alectinib and 16 months with brigatinib, and only 5.5 months with crizotinib. So lorlatinib is actually doing pretty well even in this variant, which is usually not responding very well to the other second generation, first generation TKIs. Next slide. Resistance pattern after ALK TKIs next. So the resistance to second generation ALK TKIs is largely driven by secondary ALK kinase domain mutations, particularly the G1202R. Next slide. So the clonal evolution of resistance to sequential ALK targeting therapies. So this slide shows that as more generations of ALK TKIs were sequenced, more monster ALK resistance mutations appeared. So if we used crizotinib followed by alectinib, then the post alectinib specimen usually showed more mutation, especially the G1202R, while the same was so these mutations, especially like the 1171, and so these might be even resistance to lorlatinib. Next slide. Now, this was again a lorlatinib phase 2 study with 276 patients enrolled, 228 ALK positive patients. They were, divided into various expansion cohort. The first expansion cohort had treatment naive patients, while the expansion cohort 2 had 27 patients treated with previous crizotinib only, while the expansion cohort 3 had two subtypes, 3A and 3B, in which patients 3A had patients with previous crizotinib and chemotherapy, while 3B had patients with second generation ALK TKI with or without chemotherapy. So expansion cohort 4 had patient who had two previous ALK TKIs with or without chemo. Expansion cohort 5 had 3 or previous ALK TKI with or without chemotherapy. Next slide. So we look at the median PFS. The expansion cohort 1 and 2 and 3A are doing pretty well with PFS not reached. The worst one is the expansion cohort 3B, while expansion cohort 4 and 5 are also not doing that well. So the ones who have had a second generation TKI, they are doing not that well with this schema. Next slide. So now, what is the rationale for upfront use of pan-inhibitory agents? So this was a study of in vitro, BAF3 cells which were enriched and then mutated with ALK. So they received 4-week incubation. Am I audible?
Yes, sir.
Yeah. So again, and this 4 weeks of incubation with lorlatinib and crizotinib was given. And again, if we see on the left side, post lorlatinib with the concentration of 100 nanomoles per liter, there were only 2 mutations which were found. While with crizotinib at the standard 300 nanomoles per liter dose, the mutation numbers were more than 14. So lorlatinib suppresses the emergence of single ALK resistance mutation, and upfront lorlatinib could significantly delay or suppress on-target resistance. Next slide. So we look at the resistance mechanism to first-line lorlatinib. The Crown Insight showed that none of the patient who had progressed on lorlatinib showed an ALK mutation. So all the patients who had progressed had some bypass mechanisms, which included MAP kinase, PIK3, mTOR, RTK, or cell cycle pathway aberrations, compared to with crizotinib, which had combination of all these mutations. Next slide. So this is a schematic PFS comparisons of sequencing various sequencing strategies. So first line lorlatinib again the best, more than 36.7 months. Alectinib followed by lorlatinib again 31.2. Alectinib followed by brigatinib around 30 months. Brigatinib followed by lorlatinib 25.2 months. Ceritinib followed by lorlatinib 23.7. I think so. With all this, we are clear that the best sequencing would be to use the best drug upfront, that is lorlatinib, in the first line. Next slide. Now coming to next, coming to the safety profile. So there were the main side effects which were seen were edema, hypercholesterolemia, hypertriglyceridemia, diarrhea, nausea, transaminitis, vomiting, increased weight, fatigue, peripheral neuropathy, and cognitive effects. So most of these side effects were grade 1 and 2 and were well manageable. Next slide. So now coming to the hyperlipidemia, which is one of the most common side effects. So 85% of these patients with hyperlipidemia were managed without any intervention or with just addition of concomitant medications, and none of these patients had a permanent discontinuation due to hyperlipidemia. Next slide. So this study actually showed that although a higher number of patients in lorlatinib group had hyperlipidemia, the incidence of cardiovascular adverse events was not higher with lorlatinib than crizotinib. Next slide. Now coming to the long-term intracranial safety and efficacy analysis from the phase 3 CROWN study. Next. So the evaluation of long-term intracranial safety and efficacy of lorlatinib from the 3-year follow. This data was presented at AACR 2022. So again, if we see the with baseline metastasis, intracranial progression-free, 73% of the patient were progression-free with respect to brain disease at the end of 3 years. And even in patient who had no brain metastasis at baseline, this rate was a staggering 99%. So both these curves separating beautifully. Crizotinib again performing very poorly in patient with baseline brain metastasis, the rapid fall-off of the Kaplan-Meier curve. Still without any brain metastasis, again they have reached almost 50% of the patient had intracranial relapse at the end of 3 years. Next. So a lot of CNS side effects, including cognitive, mood effects, psychotic, and speech effects, have been discussed. So, but there were no grade 4 CNS adverse events, and the incidence of CNS adverse events progressively reduces with time. If you can see from the chart from left to right, and the most of these side effects were predominantly grade 1. Next. Now coming to the intracranial safety data, the majority of the patients were managed without intervention, and CNS adverse events led to only 2 patients permanently discontinuing treatment. And the long-term analysis confirmed that CNS adverse effects remained manageable over time, and lorlatinib dose reduction did not impact intracranial efficacy. Next slide. So again, if we see the drug discontinuation rate were the lowest with lorlatinib, 7% versus 15% with alectinib and 13% with brigatinib. And although grade 3 and 4 adverse events were higher, but there were less of treatment discontinuation with lorlatinib. Next slide. Now coming to the NCCN guidelines, so the recommendation of first-line therapy include, lorlatinib, brigatinib, and alectinib as first line. Next slide. So this is all I have. Thank you, and over to the again. I think so. Dr. Piyush is not available, and so we'll be postponing that last session of his for tomorrow, and so I will call it a night today, and a thank you for all the participants of this academic feast. So tomorrow we'll be again joining at around 6:30 for the second day session. And thank you everyone for joining.
Thank you everyone for joining. Thank you, Dr. Priyanshu. support team, we can close the meeting.
Okay, ma'am. Thank you.